Okay, good morning. I'm calling this Oversight Roundtable to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Friday, February 20th, 2026. The time is 9:33 a.m. We're here today to discuss the performance of DC Department of Health, or DC Health, for FY25 to FY26 to date. We had part one of the hearing earlier this week, and here we are for part two with Director Dr. Ayanna Bennett, as well as the DC Health team. We heard from public witnesses on a variety of different issues on Wednesday, and that recording can be found on the DC Council website. Today, we have some questions, not just about things that we heard on Wednesday, but also a review of the pre-hearing, responses and the documentation that was provided to us by the agency, which is also on the DC Council website at dccouncil.gov/hearings. A little bit about DC Health, just to remind folks. DC Health promotes health, wellness, and equity across the district and protects the safety of residents and visitors and those doing business in the nation's capital. It has approximately 940 FTEs. DC Health is organized into 6 administrations, which covers agency management, policy planning and evaluation, community health, health systems preparedness, environmental health administration, HIV/AIDS, hepatitis, STD, and TB administration. I don't see any of my colleagues who are here, but some of them are in the building because I did run into them. So I'll certainly call on them when we get there. Should any of them come, Dr. Ayanna Bennett, will go to you for your testimony, but I need to swear you in. And anyone who might speak today, and I know folks can't see the whole room, but there's a whole conglomeration of individuals, which is helpful and also speaks to just how large your agency has grown. So anywho, I'll ask that you and any of members of your team who might testify today, if everybody can raise their hand so we could just do this once. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right, Dr. Bennett, when you're ready.
Good morning, Chairperson Henderson, staff of the Committee on Health, all the council members who may be watching. I'm Ayanna Bennett, as you said, the Director of DC Health. On behalf of Mayor Muriel Bowser, I'm pleased to be before you today to discuss DC Health's performance in fiscal year 25 and 26 to date. I'd like to start by acknowledging the dedication of the district's public health workforce, including many DC Health staff who you can tell are here with me today, and those watching in Anacostia, who've all continued to advance public health best practices through challenging times. Looking back, this year was one that we expected to be challenging, yet reality exceeded those expectations. Despite that, DC Health staff, our governmental partners, and community providers have persevered and continue to provide district residents with vital public health services. Going into FY25, the agency was prepared to undertake several major positive changes, launching 2 new administrations, supporting the opening of a new hospital east of the river, onboarding a new animal control contractor for the first time in over 40 years, and building a new animal health and shelter facility. We did all of those things. However, we also had equally significant unplanned major changes to manage. We weathered a hiring and partial spending freeze in the spring, transitioned the entire school health program with over 200 additional employees over the summer, navigated unprecedented changes to the vaccine guidance and approval process, and managed the abrupt cancellation and sometimes recovery of multiple grants in what would be a year-long whiplash between the Department of Health and Human Services and the courts. This fiscal year is looking to be equally tumultuous, with the longest federal shutdown in history, an abrupt major shift in the federal vaccine schedule, and a dramatic resurgence of measles cases nationally for the second year in a row, and we're only a few months in. Having weathered so much, I'm proud to appear before you to highlight DC Health's many achievements over the past fiscal year, especially given these significant challenges. One of the most significant accomplishments for DC Health over the past year was a successful transition of the district's school health services program from a contractor to staff directly employed by DC Health. This transition included onboarding over 180 staff, improving health suite infrastructure, and conducting robust parent and school engagement. DC Health is also now directly operating the school-based health centers, and recently reopened 4 of them at high schools across the district. The remaining 3 centers are expected to open this spring. The transition of both the health suites and school-based health centers will allow for improved service quality and access and better coordination between other school and adolescent health programs operated by DC Health and other district agencies. I'm also extremely proud of our team's quick response to the volatility of the federal vaccine landscape over the past year. We have ensured that despite changes at the federal level, residents in the district have uninterrupted access to needed vaccines. I would like to express my appreciation to Council for their assistance in these efforts by passing the Community Health Amendment Act of 2025, legislation that ensured eligible district practitioners can order and administer critical vaccines. DC Health has worked closely with stakeholders, including the Department of Insurance, Securities, and Banking, to promote awareness of this change and to continue to work on efforts to increase vaccine uptake, especially for children and seniors. We anticipate bringing additional measures to Council in the coming months to ensure that vaccines remain accessible and convenient to all Washingtonians. DC Health, understanding the importance of providing reliable public services, has made several customer experience improvements over the past year. Our Vital Records Division has made several process and infrastructure improvements, such as replacing our kiosks with newer models, providing enhanced staff training, improving signage, and strengthening language access, providing for an improved customer service experience within our service centers. These improvements, which are particularly critical given the importance of vital records, have made services more accessible to all members of the community. Since fiscal year 2024, our customer satisfaction rate with vital records has improved by 25%. Additionally, our Center for Policy Planning and Evaluation has applied that customer service approach to the presentation of important public health data to the public. DC Health has updated and published several dashboards, including one for preterm birth and one on mortality data, which will empower residents to make personal health decisions based on current trends. Our Environmental Health Administration has continued to build its program and is implementing new initiatives to address environmental factors that impact human health. In particular, we're excited to have brought the Brandywine Valley SPCA as the district's new animal control contractor. Since they started operations in January of 2025, they have spayed and neutered almost 6,000 cats and dogs and housed over 2,600 animals. To support these efforts, Mayor Bowser joined me to open the district's new animal health and shelter facility located in Ward 8 that offers state-of-the-art access to veterinary care, animal enrichment, and adoption services. This new facility and contractor elevate the standard of district animal care and control, fostering wellness, veterinary, and community services. Healthy homes for childhood-led poisoning and prevention programs were successfully transferred to DC Health's Division of Indoor Environment from the Department of Energy and Environment. This transfer enabled these environmental health professionals to receive support within the district's public health infrastructure and promotes improved collaboration with the broader healthcare system. Additionally, the division has distributed 557 highly sensitive carbon monoxide monitors to district residents with a focus on children and seniors in wards 5, 7, and 8. I'm happy also to share that the district continues to achieve success in reducing HIV transmission. We've now seen 2 consecutive years with new HIV cases below 200, the first time that's happened since the HIV epidemic began. This trend is due in part to the efforts of the HIV/AIDS, Hepatitis, STD, and TB Administration, HOSTA, who, even though they have faced significant funding pressures this year, has continued to implement effective prevention efforts. For those diagnosed with HIV, we have worked diligently to expand access to treatment. Over the past 10 years, viral suppression rates have improved by 14%, which means fewer people are exposed to HIV. And DC Health Wellness Clinic is an important part of the district's HIV and sexually transmitted disease prevention and treatment strategy. Thanks to the support from this committee, the clinic has successfully expanded hours to include evenings and weekends. This increased access, as well as new pharmaceutical offerings like a 6-month PrEP injectable, should continue driving progress to ending the HIV epidemic. To achieve Mayor Bowser's goal of a healthcare system that promotes equitable access across all 8 wards, the Health System and Preparedness Administration has prioritized efforts to protect patient safety and strengthen the healthcare system. In particular, we are working to address workforce pressures, including social work professionals who have been kept out of the field due to some controversial exam requirements. This challenge was especially concerning given that Black social work professionals were being excluded at a higher rate than the industry overall. DC Health responded to this challenge by establishing an education pathway that offers a practical alternative to the examination requirement. This pathway has made a real difference, with 285 professionals using it to get licensed, with almost 90% of those applicants through that pathway identifying as Black. Since passage of the Health Occupations Revision General Amendment Act of 2023, DC Health has implemented those provisions to enhance the scope of practice for practitioners and consolidate boards to promote administrative efficiency. Additionally, health professional licensing boards have transitioned to a birth month renewal system. Instead of tens of thousands of health professionals renewing all at once every 2 years, renewals will now be evenly distributed on a month-to-month basis. This improvement will decrease processing time and promote enhanced oversight during the renewal process, allowing us to resolve issues for applicants needing extra attention. In closing, the past year presented an assortment of challenges to public health, both nationally and in the district. However, thanks to continued support from Mayor Bowser, the council, and community stakeholders, we continue to achieve success in promoting health and safety and wellness for district residents. I appreciate the opportunity to discuss our work, and I'm here with my team of subject matter leaders to answer your questions.
Awesome. Well, thank you so much, Dr. Bennett. And I think the public testimony on Wednesday just sort of showed a little bit of, I had a panel where I had one person who was talking about asthma, one person who was talking about rodents, one person who was talking about vaccines, and then somebody else who was talking about food. And I was like, okay, we cover the gamut.
That's my day.
That's your day. Yeah, now, for all of the folks here, you guys know I don't like to leave any agency division out. So we got a little something for everyone. So let's just get started. Let's talk a little bit about agency management and budget in general. So, as you alluded to, or not alluded to, but you stated in your testimony, we've had some particular challenges funding wise, specifically as it pertains to federal grants being turned on, turned off, et cetera. And your agency is not the only one. We had the similar situation happen with DBH where they received a notice that they were canceling all of these particular grants from SAMHSA. And then within 24 hours, it was like a whoops, just kidding, the money is back. You stated in your pre-hearing responses that as a result of federal funding uncertainty, DC Health is planning for a potential federal funding cut of about $9 million for FY26, and that this potential funding creates a local spending pressure of about $2.3 million for staff costs. Can you elaborate for the public on which funding streams are facing the most uncertainty, and have you been provided any sort of timeline from HHS about this type of money?
So it runs the gamut, but it is a moving target. So some of the things that were cut, as far as we know, are tobacco, disease investigation, HIV, and some of our other epidemiology related services. All of those things, even the HIV, were mostly level funded in the appropriations bill. Even ones where the office that administers it is set to be eliminated. So it is, there isn't a way for us to predict. I will say, as of a few days ago, we have been asked to reapply for the tobacco funds that we were told were not going to continue. That doesn't mean we get the same amount, but that happened to all of the states who should have otherwise been cut. So we are hopeful that the fact that the tobacco money was reappropriated with the expectation that they would spend it on tobacco means that they are in fact going to give us those funds. Because funds are being cut variously to particular states for reasons that aren't clear, I don't feel comfortable predicting that we'll get those things back. But those are the areas that are the most at risk. All of them have endpoints over this spring to early summer. And for example, the tobacco money, there are 5 weeks between when they say we are applying and when
Okay.
they would need to turn the entire thing around. There will likely be some gaps, even if we get the money back.
How many, no, how many staff are we talking about?
There is a different number for each grant, so I'm going to ask my COO. Do you remember how many?
Okay. We could talk more, I guess, in detail about this later. No, come on up. She phoned a friend. In terms of, I want us, or I would like to make sure that the agency is being as transparent as possible with those grant-funded employees around the uncertainty. Not to say like, hey, go look for another job, but also so there isn't this sort of like unexpected, oh my God, what am I gonna do?
Well, there'll be none, there will be no immediate, like it's tomorrow. So
Right.
there will always be some warning. We have hedged on things that we thought we had a good chance of getting back. So the
Okay.
tobacco money, we successfully hedged. We had made plans and thought we might need to do a RIF, and now we're undoing all of those plans.
Okay, so let me ask this as a different question then. Across the agency, how many FTEs are federally funded?
Oh, 2/3.
Just introduce yourself for the record.
Hi, Michelle Blake Smith. I'm the COO for the department. I don't know the exact number, but I can tell you that we are funded at a ratio of 3-to-1 federal to local.
3 to
So the
1.
bulk of our staff are federally funded.
Okay. All right, let's talk IT really quickly. So in the pre-hearing responses, you all stated that for FY26, unfunded IT costs in the amount of about $6.5 million are funded by FY25 fund balance. Which fund balance?
So from the Health Occupations Fund,
Okay.
among a little bit of others. But for the most part, the licensing system and those things, for whatever reason, have traditionally not been included as line item budget items, but were funded at the end of the year out of that fund.
So the IT costs are
They're
for
standard and our usual. For the licensing system.
For the licensing
it-
system,
it-
okay. You were saying standard and usual as in like the computers for the rest of the agency.
No, but it is particular. There are multiple systems that are on that package.
Okay. In your testimony, you highlight the creation of the Office of the Chief Data Officer.
Mhm.
Who is that person?
So his name is Nagesh Borsay. He's an epidemiologist who was formerly at USAID and is just working now. We had started doing it as an informatics unit within CPPE. I've decided to move it to the Office of Director, so it has better purview over the entire agency.
Is
And-
it duplicative of CPP?
No, it isn't, because each part of the agency has data, right? There's
Right.
registry and other data within CHA. There's lots of school-related data. There's data around our inspections and outbreaks that occur in our food and water, that's around environmental health. And so CPBE did really surveillance level data, like what's the health of the whole city, and they will still do that, but helping everybody else improve their data quality, getting some of that data to be used in conjunction with other data to look at our HIV and vaccine data together, like those kinds of cross-agency things is not what CPBE does. They have a particular purview over surveillance.
Okay. It seems from an org chart form, the Office of the Director has grown.
It has.
But it's not new FTEs, it's movement from other
For the most part, yes.
administration?
So that chief data officer was a person who was in CPPE trying to do some of that. I tried to move their role to be more cross-departmental, and it just was awkward as a peer administration. And so it's the same position.
Okay. In your testimony, speaking of restructuring, you talk about the Office of Health Equity and restructuring some of the engagement efforts that are happening there. Can you talk a little bit more about that?
So there was not really any part of the department that was trying to monitor or improve our community engagement. That's the ability of the community to influence what the department does and how well we're engaging the community in our activities is a central part of equity. So I've asked that office to try to take that role. And what they've done is scan the agency and find everybody who is already running some kind of community engagement. We have lots and lots and lots of boards and advisory groups and other things that were not connected to each other. Make an inventory of all of those things. And they have created a council with the people who are working on those kinds of issues, and they're working on a standardization and improvement plan. So are there some trainings that everybody should have? We're right now looking at a facilitation training that the Office of Health Equity Manager who's doing this work, she's taken that training, and we're arranging for other members to be able to take it. That would better help you get opinions and input from community groups at community meetings. So that kind of improvement work. And then being able to advise and make sure that groups that don't have a lot of community engagement, and you can tell because now we're inventorying everybody and there's much more of it happening here than over here, that those groups can be encouraged to start to do that activity more than they have been.
Okay. All right, let's go to Community Health Administration. I want to start with school health.
Okay.
All right, so I think probably the biggest thing that we have going on in that arena was the movement of the school nurses from a grant that was managed by Children's National to in-house. Director, if you had to give yourself a grade on y'all's implementation of this, what would you give yourself?
I'd say it's a solid B.
A B. Okay. Now,
It was a tumultuous year and a short timeline. And if we had had different circumstances, we would have done differently. So I can imagine better. And I would say that it's a solid B with that imagination in mind.
okay, you're being generous, which is great for you and the agency. I feel like there are a couple of things that you all promised in terms of the public and in conversations with the council that didn't come to fruition in terms of the cluster model. So for instance, my understanding was that it was supposed to be 5 staff per 4 schools, which is not what the cluster situation has come to. Right
We
now,
have a different understanding.
do we? Because we can go
Yes.
back to the tape.
We have a different understanding.
Okay. Tell me more.
So the nurse who was supposed to oversee the other schools always had a school that they were in charge of.
Right. But there was always supposed to be one additional personnel than the number of schools, because if somebody was out, that person was supposed to be able to.
So we
Fill
use
in,
float
no?
people and they're not attached to that cluster, but perhaps that changed over time. It's possible.
Okay. We have high vacancy rates still. 18% vacancy rates in terms of RNs, 14% vacancy rate for LPNs and health techs. What changes are we making to improve recruitment and retention?
We're hiring some staff from staffing agencies to fill in some of those positions to make sure that we are able to staff all the schools. Yeah, and we're still hiring.
Okay. One of the significant,
I'm going to let,
oh, sorry, Sarah.
Good morning, Sarah Beckwith, Senior Deputy for the Community Health Administration. I was going to add that we have some RN, LPN, and health technician positions that are part of the recent hiring fair that are about to come on. So that 25 vacant position number will go down.
Okay. So they went through the hiring fair, they're going through the process, or is it process in terms of onboarding or processes in terms of you guys still have to interview before you can hire?
Onboarding.
Onboarding. Okay.
Yep.
All right. One of the things that came up last year in terms of the increased competition for nurse, well, everybody needs a nurse, but in terms of school health services was that some of the neighboring school districts had increased their salary offerings. Did we do a market survey to determine whether or not we're competitive?
we did and we are. We're actually the highest in the region.
Now we are the highest.
Yeah, we're the highest in the region.
Okay. All right, so in terms of staffing hours, which I think is where we get our biggest complaints from school leaders and otherwise,
Mhm.
only 50% of schools have 40 hours of coverage per week. 25% of schools have 24 or less hours of coverage per week. Is this due to the high vacancy rate, or are there other changes from agency policy?
It is due to the high vacancy rate, but the selection is deliberate in that schools who have smaller numbers or have no children who need treatments or any nurse-specific kind of activities do have fewer hours. But there's a wide variety of utilization of the health centers because it's not equal across the board of what the concentration of kids with health problems is.
Totally.
So there's some schools where we have 30 kids come to the office during the day and some where we have 5.
Right. But we also know that that could vary by day, right? Just because you had
It
5
doesn't
kids,
greatly.
just because you had 5 kids who came on Monday doesn't
Mhm.
necessarily mean that you're not going to have 20 on Thursday.
It doesn't seem to be what's happened.
One of the benefits of bringing school health services in-house was supposed to be more transparency around the algorithm that you all are using
Mhm.
around staffing decisions. We had some parent advocates who testified that this continues to be opaque. Can you share with the committee? Obviously, you can't probably do that in terms of verbal testimony, but what are you all using as inputs for the conversation about staffing decisions?
What I just said in terms of utilization number, whether or not there are kids who have high needs at that school, either the risk of high needs because they have a fragile health condition or a high risk allergy or need some kind of procedure during the day like catheterization.
Okay, but that's all based off of information from what? The Universal Health Certificate or something else?
And yes, the universal health certificate, medication allowance,
Okay.
paperwork, and from parents.
So maybe there is then a disconnect in terms of the data that you guys see and then the data that you report out, because when we look at the percentage of students who've actually turned in their universal health certificates, we're real low. Students with a universal health certificate on file for FY25, we had 28% of students who submitted one.
Yeah, those are the students, a lot of those are students who have needs, and that is why we have that. But we also are allowing other ways for students and their physicians to tell us that they need things. So students turn in a medication and an allowance for a medication that don't necessarily have done their universal health certificate. So we perhaps unfortunately have multiple ways that we can activate the nurse's office.
So does the universal health certificate have a purpose?
It does. It's not our regulation. It's Aussie's.
But you're the public health agency, so wouldn't you make
Yeah,
a recommendation about whether or not this piece of paper, which some pediatricians charge families for filling out, actually has value? Because you guys have stated you plan to revisit the electronic universal health certificate discussion during school year 26-27 after the school health services program is incomplete. But there's got to be a better way to do this without
Right.
chasing a piece of paper and then having a nurse have to spend their time inputting.
I do think there's a conversation to be had about how much data we need and how often. But we need to have that conversation with Aussie.
Okay. Can we ask that DC Health be sort of the initiate of said conversation with?
We will do so.
Okay, good. I'm just saying, also as a parent, when I submit the form and then I get an email twice that says that the form has not been submitted, and then I do a forwarding the email that I sent, in August, nonetheless. Okay. We heard from Impact DC, the asthma clinic that's run out of Children's National, the work they do there about the high rates of childhood asthma. Obviously, you guys would see that through some of the asthma medication plans. And I want to thank again the agency for your willingness to work with us on the undesignated albuterol that's now deployed to schools. She suggested that DC Health restart the telehealth program and school health suites to allow for more children to be screened and treated for asthma without needing to miss school. Are you all considering, I know that that was a specific initiative of children's when they were leading the school health services program. Is this something that you all might be thinking about?
I'm willing to have a conversation with them about it. I'd like to be able to have a system that's accessible to kids who don't see doctors at Children's and who have other issues. So we need to reimagine what it's for, but I think that's in a program that we should think about who it would be valuable to and how we want to structure it.
Okay. A partner in your cluster, Department of Behavioral Health, is planning for a complete restructuring of their school-based behavioral health program. Have they talked to you guys about it?
Yes, we are in constant contact with them. So I'll let Sarah talk about what they've discussed.
We've been meeting regularly to build out a more robust referral pathway from our health suite team members to the school behavioral health, mental health counselor, both so that it is standardized and we can monitor how many referrals are being made. And then we're also collaborating more closely on offering behavioral health trainings to all of our health suite staff that are also offered to the mental health staff.
Okay. All right. So in the pre-hearing responses, you all indicated that DC Health is almost completely implementing the access to emergency medications. You stated that the hiring freeze, you were unable to, during the hiring freeze, you guys were able to use existing staff to implement. Do you all still plan to hire for these positions or will they be repurposed?
I'm not sure we need them. We used our
I'm sorry, say that clearly.
no, but circumstances changed. So when we initially proposed this, we were not the restockers. We didn't have a logistics plan for the schools.
Yep.
We didn't have any space or staff or anything designated because we were not the school runners. That has changed, and we've had to build a logistics program to stock all of the health suites and to manage the health suite physical environment. And now we have that. So adding something onto that infrastructure, which we've had to build, is different than trying to build an infrastructure when that wasn't our previous job.
Okay. I'm gonna clip
So,
this
I'm
and
not
send it
sure.
to our team over at ORA. Next time you guys ask for 3 FTEs to start a
But
program,
circumstances change.
I know, but in those
The world
circumstances,
changes between the moment that we ask. and
you
then-
guys were able to figure it out. So that's why I'm just sort of saying,
But I was
like,
able to figure it out with money that was otherwise somewhere else. So if the contract had stayed at Children's, if the grant had stayed at Children's, then that funding would be at Children's and I would not be using it. So they were
oh, I
using
see,
it.
you were using
Yeah,
funds.
they were
from-
using it to logistically staff their own health suites and put the materials in the health suites. So I have to now make sure there are Band-Aids in the health suites. If somebody has to go around and deliver Band-Aids, they can also deliver the undesignated medications and take them out of the cabinet. So that is essentially what happened. We have drivers and we had to do all those things and essentially hire and create the system that they had with the same pot of money.
But now
So
we're able
that
to
pot
sort of consolidate.
yes. So I'm adding a duty onto a system I had to build rather than building a new system.
Okay, I don't want y'all to have to reinvent the wheel. So the fact that we were able to consolidate, I think is a good thing. But now I'm like, I gave you 2 extra people you didn't need. Now I gotta figure out how to get those people back. That's okay. No, it's
I
okay.
guess I don't still have them.
That's entirely possible as well. Okay, so in your pre-hearing responses, you all indicated that there were 4 schools that have 0 AOM trained staff.
Mhm.
What are our conversations with these schools? Because I know what the law says, and having 0 AOM staff is unacceptable.
We work closely with DCPS, with the DC Public Charter School Board, with the DC Charter Alliance. So we're working through our sister partners to support those schools, to identify team members at those schools.
So we've communicated with these 4 schools around you are not currently in line with the law.
Yes.
Mhm.
And I will have to check, but they don't get to be designated as having AOMs until they complete the training and get certified. So they may be in process. We can check for you.
Okay.
True.
I mean, I think that is also something too for those school communities. If you have no AOM trained staff, are they also like, what does their nursing coverage look like so that if a young person needs, like, who's delivering medication if nobody's?
Well, that would be a school that we would, one, have to have a staff person at,
Mhm.
and two, have to replace that staff person if they called out, which we generally try to do, but that would be considered a school that we had a critical
Issue.
need to replace that staff person if somebody called out. So we'd have to float someone from somewhere else.
Okay. There are also 29 schools who only have one AOM staff that is trained. Have we reached out to those schools?
Yes.
Okay.
Same process.
Same process. Okay.
And we'll check to see who's in process and
Mhm.
and whether or not they just have been slow to complete the training.
Okay. Can we follow up on this? That just gives me a little heart palpitations of like, you got nobody on your campus, and also you're not following the law. So we'll follow up on that part. We heard some public testimony, speaking of public charter schools, where they would love for DC Health to pilot their ability to hire their own school nurse. Have you all considered this strategy? It's something we did finally get DBH to agree to on school-based behavioral health.
Mhm.
They had some strong success in year one, kind of tapered off thereafter. But there are still some schools who are doing it where essentially the agency is issuing them a grant to be able to hire and do the supervision of a person. Is that something that could work in our school health program?
I think we'd have to consider it, which we had not done, and look at what the problems are. My immediate concern is, what is their process for call-outs? And when you have a network of people, you can float someone from somewhere else, you can use a manager. But if you literally just have a single person who then goes on leave, gets sick, it sounds like a vulnerability to me. So I would be concerned depending on the level of health of the students at that school. But I'm happy to talk about it. The amount that we would be transferring that to them could not be the amount that we would pay for an RN who has other responsibilities. So we'd have to talk to them and see if that's actually viable for them to get a staff person and then to be able to maintain a standard where they had some available medical advice and presence when they needed it.
Okay.
They would do it as a network between them.
Yeah, I mean, I think there's 17 charter schools already who hire their own nurse. I'm not sure what their particular processes are. Obviously, hiring your own nurse doesn't absolve you of the other requirements around AOM. So I think if you're open to the
If
conversation.
they want to bring a proposal, we are their partner. We're happy to talk to them about it.
Okay. Hopefully Charter School Alliance was listening. Let's talk about vaccines a little. It's sort of pediatric vaccines. So you mentioned in your testimony about measles. Last weekend, I happened to be in sort of the epicenter of that for the country.
South Carolina?
I was in South Carolina. It's like, oh, Lord, okay, I'm vaccinated, but still. Are we seeing any trends this school year, given the amount of, I guess, given the sort of the about face that the federal government has taken in terms of pediatric vaccines?
I know we've seen some erosion in terms of nationally where people are having somewhat lower vaccination rates. We are in much better shape than we would have been 5 years ago with this. So I'm feeling good about most of the schools in the district. We do have individual schools with low rates, and we are working on trying to identify and counsel them. I'm not sure everybody understands what it means to risk an outbreak. It's a lot of time off for kids, and that's for the kids who don't even get measles, but just who are exposed, who are out of school for multiple weeks. It is quite a dramatic blow to a school that I'm not sure some of our lower vaccination rate schools are entirely prepared for what that would mean. So we're going to make sure they are, and that they have a plan and they understand what we would do if we had to come there because they had a measles outbreak. But we are, for the most part, we have quite good coverage at DC schools for measles, and we feel pretty good about where we are. We're not where we need to be. We have a couple % to get to where we have confident herd immunity.
Yeah.
We're very close.
So the Washington Post, I think it was them, back when they used to cover DC, they did a map that looked at vaccine rates by school in DC. And, we've got some, I would say, troubling spots, in particular schools east of the river. And as you guys are thinking about sort of the engagement arm of the Office of Health Equity, how is DC Health as a public health agency sort of deploying to those school communities, or what information are we providing to those school communities that can, one, help educate parents, some of whom might be vaccine hesitant, and two, if necessary, if we got to partner with Children's or pharmacy or whatever, bring the vaccine to the child, because sometimes it might be a situation where, the parent can't take off to go to the pediatrician's office just for this. Well, I think MMR is like a 2-shot
It is.
series. So are we thinking about it from those particular strategies? Because I see this as a health equity issue. And I think as the public health agency, you all have a role here of when we identify, very targeted places where we're not seeing the vaccine levels that we should be seeing. How do we at least try to approach it?
That's what the team's working on now.
Okay.
You want to add anything, Sarah?
Sure. We are working with our HIV/AIDS, STD, TB team to learn from them and their outreach methods, because we know that they've seen a lot of success, and so we can take those best practices in reaching hard to reach families, and have conversations about MMR vaccines and overcome that hesitancy. We're also meeting Children's National next week to coordinate and align on some of our measles planning and response activities. And so reaching those hard to reach families is part of our conversation next week.
Okay, good. I'm glad to hear that that's happening. I would love to see us be able to deploy something for those schools before the end of the school year. And not necessarily just focusing on measles, because I've seen some very weird comments from some people about chickenpox. And I had chickenpox. Why you want your child to experience chickenpox, particularly in the summertime, I don't know why people want that to be a thing, because it comes back as shingles. But I think it's just sort of in general around certain school communities. We just need to have a deeper conversation with them and not just assume that the pediatrician's office is getting the message across, and maybe it's partnering with PTO organizations and otherwise. But if we could take the spring before we hit summer, where we can
That is our goal.
Okay.
We are right now trying to shift the focus. We have been focused around exclusion a lot as that got implemented, to try to focus more towards the springtime when people are still in school, because it really is hard to do when they're not, but also right around, just after they've enrolled and they know in the next school year, they're the ones who are going to need vaccinations, to give people plenty of time to go to the doctor and get them with some support.
Yeah. One of my sorority sisters is a principal at one of these schools in the hotspot. And I don't think people understand, it's not just the child who is infected. It's everybody who was around them and the little friends got to sit at home for weeks.
Yes.
And that's
I
not
don't think they know either. So that is what we're going to explain to them.
No, some people like to.
Well, I think what people have not, we've had decades of having very few measles cases, not all that much chickenpox. As people vaccinate less, so our recent spate of cases came from folks on a bus coming up for an event out of Florida, where they have very poor vaccination rates at the school they came from. They all got on a bus. Some of them had measles. they gave it to people, so the kind of brush fire that's happening in South Carolina, what may or may not be happening in Florida, it's very close to us. It's very unlikely that people aren't going to travel and bring those. So the idea that it's a thing you don't have to think about at all is historic at this point, and people have not caught up.
Yeah. Okay. Let's talk about chronic disease prevention and management. So in the FY24 performance oversight response to this was a year ago, you all said that you were going to finalize and publish a chronic disease data dashboard. But this year you said this dashboard is now internal. Why the switch from at first a willingness to make this information public to now only doing it internal?
We're doing it internal this year so that we can fine tune what the measures are. It does take work to put together a dashboard and make sure that it's not wonky and it's real easy for the public to understand. So we have completed our internal dashboard. And so now we can look to publishing it to the public.
Okay.
We use them for two different things. I just want to point out, some of the dashboards are used to monitor the performance of different health facilities or things like that. And some of that's either not reliable, but like we know that the data coming in is only partial, and so we wouldn't want to publish that, or it's got different elements. And there are elements that make sense to share with the public that we know are true. We don't think we have big missing chunks of data or other issues like that. So just making sure it's actually validly saying what we think, what someone would instinctively think it says without lots of caveats is the standard for a public dashboard.
Okay. I want to commend you all for the blood pressure control strategic initiative that you all prioritize, particularly for Black men in wards 7 and 8 who have a high risk of poor cardiovascular disease outcomes. We heard testimony a lot last year about, residents wanting a particular focus on men's health. I think this initiative is only 1 year old, but is there anything that you have seen thus far? And do you intend to expand it in the future?
Yeah, this has been an exciting initiative. It's been a process where as an agency, we determined what are our priorities. This is not tied to any federal initiative. So we have 3 components. There is an outreach component, and this is one of the most exciting. We know that to truly build a healthy community, you need a culture of health. And in particular with men and with Black men, culture is set up to tell you you need to be strong and not engage at your doctor's office. So we have created, worked with our partners to create a community influencer initiative. And so we started with Martha's Table. And so through their district dads program, recruited and trained 20 men who are community influencers who have gone out into the community and been talking about how to be healthy and the importance of going to your doctor. So we reached about, I think it was 700 men over the summertime. And our plan for this year, this summer, we are releasing a competitive application. So this was our pilot. We worked with Martha's Table. We worked with other CBOs that can do this work. So we do have a competitive application coming out so that we can recruit more CBOs to do this work and finalize and scale up this, what we're calling a community influencer model.
And there are other components that are the quality work that's happening at the health clinics to make sure that they're able to follow these patients and that people aren't lost to follow-up. So some of the navigation work that we're doing among lots of different kinds of illnesses, this is going to be buried into that work as well. So hopefully all the different pieces that to whether or not somebody gets care.
Payment.
Yes, and payment models.
For the
Primary care.
For primary care.
Yeah. Look, we're looking for different payment models. We're talking a little bit to DHCF about how their pay for performance or other models might be able to align with this. We'll have to look at how we can talk to the MCOs or other partners, but we're still developing that part.
Okay. In terms of still in this area of chronic disease management, you all established a pharmacy wellness hub in FY25 to expand access to self-management programs. So you worked with 4 independent pharmacies and 1 CBO. Is this what we were just talking about? Is that part of it as well, or is this something completely separate?
That is part of the clinical quality improvement component of the blood pressure strategic initiative.
Okay.
That component actually is funded by a CDC grant, but we worked with pharmacies as a touch point in the community where people come to pick up their prescriptions, and train the pharmacies to implement diabetes management education, diabetes prevention education, and blood pressure monitoring education.
Okay. I mean, you also distributed 85 blood pressure monitors as part of this initiative. What does evaluation look like for this?
Yes, we have an evaluation plan for each component. So we are able, and because we're tied with the FQHCs through our federal grants, we do have patient data, so we can monitor blood pressure control.
How long is this initiative going to be in place?
This, I believe it's a 5-year initiative that we have as an agency. So we're in year 2. And the blood pressure, the pharmacy hub, and the blood pressure self-monitoring, that is part of our ongoing CDC work.
Okay. I think this could be very interesting as we sort of have an overall conversation, not just from the perspective of men, but also women and perinatal mental health. We were talking about blood pressure, hypertension, all of these different things. And, Hospital Association testified that we have seen some decreases in terms of hypertension through the work that they've been doing with the Perinatal Quality Collaborative. And I think that you guys also established a patient navigation pilot with 2 FQHCs around supporting patients living with hypertension, which is a completely different sort of group. How are we making sure that each individual initiative is not duplicative of one another and that we're coordinating on some of these things?
What we're trying to do with the initiatives is take something that is a deep local health problem that we have as a priority. And this one for me is really about longevity. It's a big driver of our longevity racial gap. And really try to do things that are transformative, that will become part of how the department does its work. So it's not so much that the initiative stays around forever, but that becomes part of regular work. So it's taking lessons from other things that we do. Like a lot of the navigation successes were initially around initially around breast cancer. And lots of that work around how do you get quality, what is a navigator supposed to do, how do we work with the FQs, are then being translated to work on other problems. So how do we take something and make it the way we do the work rather than put something in place that is interesting for a few years? They do overlap to some degree on purpose. So the lessons of navigation, we're adding on to that one navigation about this. We're adding on to the pharmacy stuff that really could only have been about diabetes easily, and adding on to make sure that also gets folded into the blood pressure work. So we're trying to make sure that these become functions, not just projects. So how do you work with pharmacies as a hub of wellness? Whatever our topic is what this is about, so that we can fold into that function other things as we need to.
Okay. I like that approach. I also appreciate that we are focusing on particular areas that of a concern, for DC, not just something that's being driven by whatever the federal priority is, but heart disease, hypertension, these are issues here. I think in the data that you all provided, that was the leading cause of death in the district is heart disease. Which I don't think a lot of people can appreciate. That's how serious of an issue it is for residents and how cross-cutting it can be for all parts of society. We've been joined by Councilmember Wendell Felder from Ward 7. Councilmember Felder? 10 minutes.
Well, thank you, Madam Chairperson. Good morning, everyone. Thank you, Director Bennett and members of your senior leadership team for being here. It's always good to see you. At the end of the day, it is no secret that a healthy district is a strong district. I appreciate all the work that DC Health is doing every day to identify, control, and prevent diseases and other health risks across our city. But we also must be honest about the moment we're in. Our healthcare system is under real pressure, whether it is rise in Medicaid costs, change in benefits, and families who are unsure about what coverage will look like moving forward. That makes prevention more important than ever. Residents are counting on DC Health to help to prevent, or rather to help them stay safe on the front end. So we're not just reacting to crisis, but building a stronger, healthier baseline across the district. When prevention, education, and disease control programs are working well across both physical and behavior health, people are less likely to end up needing care that may be hard to access or afford. This is especially important in communities like Ward 7. Families there are worried about losing coverage, losing trust their providers, or simply falling through the cracks of what can feel like a very complicated system. We know that Ward 7 continues to face disproportionate health challenges, including high rates of chronic diseases and ongoing environmental health concerns. Additionally, I often hear from residents and business owners about rolling control and unsafe rehabilitation facilities. Today, I'm hoping to learn more about what DC Health is doing to keep our residents healthy, whether that is making sure our school-based health programs have what they need, rolling populations are being controlled, or our city is ready to respond to public health emergencies. I also want to hear more about what DC Health is doing to make sure our rehabilitation facilities are providing quality that is safe for residents. Currently, I have at least 3 complaints about rehabilitation facilities in my ward, and to date, these issues have been unresolved. And with that, I look forward to today's discussion. I'll jump right into my questions, Director. Ward 7 continues to experience some of the highest rates of preventable health challenges in the district, including chronic diseases, infection diseases, and environmental health concerns. We want to make sure that we are seeing real progress, not just citywide averages. Could you speak to what is DC's health specific plan to reduce preventable health burdens in Ward 7?
So I will say I don't have a specific plan for every ward, but we do have specific plans around populations where we know that people share habits, they live together, they have things in common. So we have just been discussing a plan about the hypertension control and chronic disease control among Black men. And that is really both because that's a group that has a lot of issues in this area and we need to focus on, but also if we can solve some of these challenges for Black men who have some of the biggest barriers, we can solve them in a way that then benefits the rest of the community. So that is one area where I know that we have a focus that's really gonna benefit Ward 7 residents more than it might anywhere else in the city. We're also looking at being sure that we're including the CBOs that are doing the service provision in Ward 7 in all of our work. It is one of the places that we focus on in almost every one of our areas of interest, both the ones that you've mentioned, plus HIV and other focuses. So 5, 7, and 8, because those in our data show that those are areas where we have the most significant issues, those are the areas that we focus the most of our attention, and Ward 7 is absolutely always on that list.
How do you measure success? Like, what measurable targeted indicators are you looking for when you're doing this work in this community?
So many of the things that we're looking at are slow moving.
Okay.
So, because we're looking at population level movement. But one of the things that we're trying to get better at is looking at how people are functioning by looking at what our health data looks like in terms of people's use and response to the health system. Do we have people going to their chronic disease management? Do we have women following up on, able to successfully follow up on their breast cancer diagnosis? And then are we getting outcomes from that? Do we get high blood pressure control? Do we get people successfully completing treatment? So that is what I'm looking at. What is the experience on the ground look like for whether people are able to get what they need?
Could you speak to how will DC Health improve data reporting and provide consistent ward level performance dashboards?
So we've been doing some of that improvement in our publication so far. You'll see some of the dashboards that are listed in our response that have come through. And many of those, almost all of them, would show ward level data on one level or another. What we're doing now is trying to consolidate all of that work. We've moved some of our informatic functions under a chief data officer in my office, so I can have a little bit more oversight over it, and it can have a department-wide influence and bring all of those data dashboards and develop some more and additional ones that can be published on a single website. And we're in development and contracting for that right now.
Thank you, Director. And Director, we know that prevention, especially for young people, determine long-term health outcomes. Ward 7 has a large population of youth, and many families rely on school and community-based services. My question, Director, is could you speak to what your agency is doing to make sure that you're hitting as many young folks as possible, to talk about the importance of whether it's chronic diseases that may persist within our communities, or even some diseases that are preventable?
Well, we do health programming that relates to children, both at our school health program, but also just generally as the community health administration. I'll let you speak to that some if you like, Sarah. What I would say is that as we're taking over school health and better able to coordinate with the schools more directly, particularly at the school-based health centers, we're focused on that, in particular, that transitional age group, where they're transitional age youth who are that 16 to 24, as they age out, getting them in that early stage to get them to start independently coming to the clinic, to really learning about their health, to trying to influence their ability to feel empowered around health decisions, and to really be looking at their health as individuals and coming adults.
Now, how are you working with DCPS, DBH, and other community organizations to support youth in Ward 7?
I think that's improved greatly over the last year,
Okay.
partly because of the school health integration. We've been working with DBH, really focused with the school health suites as an anchor, but more than that, on what their behavioral program for youth is and how that can integrate with our other health programs. And then looking at DCPS, we meet with them. We always had a relationship, but now that we're more directly in service together, it's been much closer and we're integrating more closely.
Director, you mentioned that it has improved. Could you speak to what, if any, existing gaps still persist?
I do think that we want to get our own staffing and policies completely in place. We've been rebuilding some of that after the transition. We want to be sure that we've got more regular interactions with all the other health programs that are happening in schools. We've had some connection to the DBH programs, but it had not been substantial in the past. So our health programs that aren't the school nurse in particular were not necessarily integrated with DBH. We're better able to do that now. And then DCPS has a school health program that we want to be able to talk about how we can talk about other parts of community health administration, not just school, and how those might integrate.
Now, you mentioned DCPS. Could you speak to like coordination efforts? Are you guys meeting quarterly, monthly? How do you guys coordinate services?
Are actually using juvenile settlement funds. And we are supporting a health education manager at DCPS. And that person coordinates training and education on a lot of different health education topics for students. And through that relationship that we have, we meet monthly and talk about opportunities to align on health education and promotion for students. And in terms of other CBOs that we partner with to reach our youth in the community, we partner with SMART from the Star East of the River, Strengthening Collaborative. So we have several community partners.
Thank you for that, Madam Chairperson.
Thank you. Okay, I want to talk a little bit more about maternal health or maternal and infant health. So in the pre-hearing responses, you all stated that DC Health released a 5-year DC Health Maternal Health Strategic Plan in September of 2025. Where is it? We couldn't find it on your website. So where is it?
Yeah, I would like Dr. Tiffany Gray
If you guys
to
could.
come up. She is our expert.
Okay. Oh, the mic was already on, Dr. Gray.
Sorry.
Thank
Good morning, Dr. Tiffany Gray, Maternal Health Team Program Manager at DC Health in CHA. So the 5-year strategic plan, we had the initial draft that was completed in September 2025 and submitted to our federal funders, HRSA. There are some additional required changes, and so we are working on those and resubmitting to HRSA, which will be resubmitted at the end of this month. And once completed, it will then be released through our maternal health webpage on DC Health, but also to our grantees and our maternal health task force.
Okay. Then, okay. That is because we were like, oh, this is great. We have a strategic plan. Oh, wait, there is no plan available. So the latest maternal health data we have is from 2023. What's the status on an updated report? New data, new info. Are we gonna?
That would be in CPPE. They're compiling that report. So I don't have a delivery date for you. I can give it to you at a later date, or we can wait till we're talking to them.
Okay. All right. CPP will be next. The FY26 approved budget included $750,000 for a competitive grant program for teen pregnancy prevention. What's the status of this particular grant?
This funding, we did go through the RFA process. When we received the local funds, we're now at a place where we are waiting to hear on budget decisions that are being made right now.
Okay. Budget decisions for when? This was a FY26 grant and we're currently in fiscal year 26. Are you all pausing this, which I believe was a council enhancement? Are you choosing not to move forward?
We will have to find other funding for it. That's not what I mean.
Okay.
So it was paused because we, in the consideration for mid-year cuts, we have very little local funds that are not related to schools at this point. We had to use every local fund we had. And so we will have to figure out what we can shift. We have between that proposal and some of the other uncertainty around other funding sources, we've needed to pause in order to be able to be sure what we had available.
Okay.
And I don't know if we'll have the full amount or how much we'll have at this point.
Okay. When will we know?
We can give a more definitive answer in a couple of weeks.
Okay. There was one grantee for the preterm birth reduction initiative grant program that lost their funding in FY '26 due to their inability to meet the grant requirements. What happened to the 350,000 that was, I guess, could have been slated for that? Are you going to repurpose that money or give it to a new grantee? What's happening with that?
So yes, the funding was reduced. I believe we reduced the overall funding for the preterm birth grant for this new year because of the reduction for the grantees. Currently, we've remained with the 3 grantees, Unity Healthcare, MedStar, and Community of Hope. And so we, for this current year, MedStar and Community of Hope were awarded $350,000, and there was a reduction for Unity for $300,000.
Okay, so the 350,000 that would have gone to a
It-
grantee has been repurposed for somewhere else in the agency?
I'm not sure. I'd have to.
That adds up. We might have also received a cut in our preterm birth allocation. So we can get back to you on that.
Okay. Because now I have a grantee who believes that they were cut because they didn't meet the grant requirements, but now you're saying, nope, you were cut because there was less money that was available.
They were cut due to not being able to meet the grantee requirements. So in the last year, they were put on a corrective action plan.
Okay,
And we worked to provide technical assistance, throughout that grant period to get them up to a par. But due to them not meeting the established requirements in the corrective action plan, the funds were then reduced for the following year.
okay. Is it accurate that DC Health is now administering the DC map instead of Department of Behavioral Health?
We are. Historically, for the past few years, we have been providing funding through an MOU to the Department of Behavioral Health to support the DC Mental Health Access Program and DBH. And so we use our federal funds from a HRSA grant to support that initiative. DBH had a contract with a vendor, and us 2 agencies had a conversation last year and said, it would be more efficient administratively if we transfer that contract to DC Health. So we did that. There was no change in service delivery to pediatric patients, to the pediatric providers. So
Okay, so who,
nothing has changed.
did you all have the staffing expertise at DC Health? I mean, it's contract management.
So
So
contract, yes.
which,
It aligns with our pediatric mental health access grant that we
Okay.
have through HRSA.
okay. There were several public witnesses who testified about the number of newborns who are lost to follow-up after not passing their initial hearing screenings. Now, I'm not sure in terms of the accuracy of their data, but they said 80% of newborns in the district who fail their hearing screenings at the hospital are lost to follow-up. And they said that while Maryland and Virginia require hospitals to collect better contact information, including pediatric information for that newborn, et cetera, the district only collects the name and the phone number for the parent, making it very difficult to follow up. Is this something that we can look at in terms of improvement?
I'm going to start you off and then let you follow. So the number they looked at was not a percentage. It was a number. So it's not 80%, it's 80 babies.
So I asked the question.
Yeah, that's okay. That is not a low enough percentage. We want to do better than that. So there is some work being done in that area.
So we have an early hearing detection and intervention grant from HRSA. And part of that work is we have a team member that follows up with every family that fails their initial hearing screening so that we can make sure that they get connected to a healthcare provider that can do that second screening.
Okay.
And we're currently at about a 19% loss to follow-up which is higher than we'd like it to be, but it's lower than the national average.
Okay, so for if a infant fails the screening in the hospital,
Mhm.
you all are getting that information
We are,
and doing that particular follow-up. Okay,
but there's always opportunity to improve.
yes. I would just say from a statistical standpoint, right? 80% is different than 80 as a number.
And that was old data that on a CDC website that had not been updated.
Okay. All right. Just really quickly on home visiting to close out that particular conversation. DC Health developed its own home visiting program in-house called Safe Care Augmented.
Mhm.
And you're using McV funds. I think the question that I have is like, do we have too many are there too many pots? What do we call it? All right, hands in the kitchen on home visiting. Because we got like, I don't know, 2 or 3 different home visiting grant programs that are kind of operating. Is this not a place where we can gain efficiency?
This is also part of our work with Children's Law Center to bring together a coordinating council so that we can align our efforts. We need different models. Families have different needs. Our federal programs have very strict guidelines. And so it is helpful to have other models that are more flexible to meet the needs of parents.
I know, but I'm just saying from a funding standpoint, in the last, I don't know, 5 minutes, we've talked, right? I've got, $350,000 per grantee on one home visiting program. And then for McV funding, we're spending another $670,000 on another home visiting program. Are we even checking to make sure we don't have participants who are overlapping?
We are. The Safe Care Augmented is a shorter intervention. So some of our McV home visiting models are several visits, and that's a large requirement for our families. So safe,
Finance has home visiting.
yes,
Everybody's
yes,
home visiting. Why can't we all get together and
We
work
are.
on the playground together?
yes, we are.
And it might,
CFSA also does home visiting
Aussie has home visiting.
through Head Start.
Yeah. I feel like this is one of those places where I don't want to decrease the number of families for whom we are serving, but I feel like there could be some efficiencies gained here by not having 6, 7 different agencies operating their own version of a home visiting program. Okay, I'm over my time. Councilmember Felder.
Thank you, Madam Chairperson. Director, residents depend on strong public health enforcement to ensure safe homes and neighborhoods. We regularly receive complaints from Ward 7 residents about rodents, housing conditions, and environmental health concerns in apartments and commercial areas. Could you speak to what steps is DC Health taking to strengthen inspection capacity and respond timely in Ward 7?
For the most part, we don't actually have any authority over most of the indoor hazards that you just mentioned. So rodents on public property, it's clear. Rodents in an apartment building is not, and in fact, we don't. We do treatments in people's yards, but there isn't necessarily authority to do that. We just talk to them about it and get an agreement. So the hazards of mold and some of those other things exist in DC law in building codes, but they don't in public health law or regulation. We are currently writing some of those, so you will see some of that legislation and regulations come through, but I don't currently have any authority to do anything about that. I can't declare it a health hazard. I can't do anything about it, and I don't have any inspection force that would have any regulation to enforce around many of those hazards that get reported to us.
Well, the areas of public space, like say along commercial corridors, Like, could you speak to like how many inspections are conducted annually from your team?
So for rodent abatement, we do that on a complaint basis. So
Okay.
people let us know that they see rodents, and then our team responds to it. We have a lot of calls and responses every year. I don't have my environmental health senior deputy here, but we can get you more specific numbers.
Okay.
But that system is really based on complaints, and that's not a bad system because people are fairly good about complaining about rats. And so that will tell us where we know we have high density areas. This spring, we're going to work on trying to take some of that as pattern information and do some proactive work around some of the areas where we know we're getting high density complaints. But that is how that system works. And that is the outside of businesses. The business owner has responsibility for the inside of the building. Those we do notice of infraction around, and then try to use the court system to move people to ameliorate those.
Could you speak to what's the average response times for complaints?
We're consistently under 3 days
Okay.
for our rodent system.
Okay.
For the other complaints where we do try to assist people when we don't actually have jurisdiction to do anything about those complaints. And usually we respond within a few days to at least try to work people through what they can do. It'll be a system we're going to have to build and determine who's going to take those items. Our Healthy Homes team that's come over from the Department of the Environment that works with lead prevention they've taken on carbon monoxide, and they will expand their purview to add on some of these other hazards. We'll have to figure out what the enforcement to funding mechanism for that is, and it'll take some time to do that, but we'll get the legislation to you in the future.
I will say for the record, like we get a ton of complaints in Ward 7.
Yeah.
And my question, Director, from your opinion, do you feel like you have the staffing level sufficient to really address the concerns?
For the things that we are responsible for or have some authority over, we feel comfortable. There's always more. I don't know that we're going to win the war on rats, so I think we could probably add staff endlessly to that and still have plenty to do. But on those other issues that we currently don't really engage on, mold, heat, there are a lot of things that impact human health that happen on inside the home. We don't have staff dedicated to that because there isn't a funding source related to that. So that's part of what we're doing as we're looking at the legislation. What would that be?
Okay. Yeah, I would, I'm excited for the legislation. I will say, just for some context, we get a number of calls from, commercial corridors, business owners. We have a lot of vacant and blighted properties,
Yes.
and then we have some slumlords. I'm pretty sure you've been following the work of the Attorney General's office, and all of that trash just kind of creates a feeder nest for,
Right. And we can do
unwanted
something about
visitors.
the rats and do an infraction, but what we'd like to start to think about is to operate a little bit more like the Department of Buildings, and where you tell me there's a problem and you get a chance to do it, but if you don't, then we do. We're not set up like that, and our authority isn't structured in that way at the moment. So
Okay.
we can try to convince you to do something about it, but short of that, there isn't anything more we can do.
I would love to help. My office is here, readily available. We have a number of ideas and suggestions, so
Okay.
I would love to follow up offline. Well, public health emergencies historically affect vulnerable communities the most, including residents east of the river in Ward 7 and 8. While we hope emergencies will never occur, we must be prepared. My question, Director, is what investments are being made to strengthen emergency preparedness and response capacity for residents in Ward 7? Yes.
So we've made some investments in our emergency response. We've added a mobile vehicle to help us do some of the organization we would need to do around setting up mobile health facilities or medication distribution or the other things that are our responsibility. It's a year of transition with the federal government. So some of the things that we're used to, like the federal stockpile, I think there's a little bit of court case around this one too, but may or may not be decommissioned and become local responsibility. So we're in a transition period, but we have made some investments and to be able to be more mobile and to be able to set up remote and as needed facilities. We're looking to take some hospital bed, some ad hoc hospital bed setups from the feds as they decommission what they're used to making available to us. So we're making investments, but it's a transition year in terms of deciding what's going to be available.
No, I truly understand that. I know it definitely, to say the least, is a transition year. Just a follow-up question. How are you engaging with communities in preparedness efforts, as well as what organizations in Ward 7, if any, are you engaging with?
For the most part, we engage with healthcare facilities, and that
Okay.
means both the hospitals are our primary concern, but not only, but also our nursing homes and other residential care facilities to be sure that they have plans that they can institute if they have an emergency, that they involve us when they have even short-term emergencies, which for the most part they do. So a nursing home loses its heating, it's required to tell us, and we can sometimes assist, as we have in the past. That kind of local emergency we've been able to respond to. The communication with residents is really primarily through that mechanism. We don't directly necessarily have neighborhood teams, but we do have Medical Reserve Corps, which people in the healthcare community are part of. That creates a volunteer corps that would roll out for emergencies like that.
Could you speak to what gaps currently exist in the district's public health emergency readiness system, particularly in high-need communities?
There's always going to be concern about people's ability to transport themselves away from hazards. So we try to make as much communication and understanding between us and emergency management around being sure that we're speaking for and representing vulnerable populations when we're planning and responding to emergencies, that they're remembered. Facilities that have lots of vulnerable residents, we take the role of making sure that they're prioritized for debris removal or checking in, or that we are the people who keep track of whether or not they've got the equipment that they need. So that is where we see our role in making sure that we're available. But those gaps persist, I think, for most emergencies in terms of being sure that we've got enough transportation or enough medical support. And so we're constantly trying to keep that number higher.
Thank you, Director. Madam Chairperson.
Thank you. Director, I want to talk about healthy food access. And then I
Thank
can
you.
move on from CHA because Sarah's been sitting in the hot seat for a little bit. There have been a number of agencies that were engaged in the Sunbucks program. Do you anticipate that DC Health will continue its role operating the call center and administering outreach grants?
So I'm still here. We are not going to. So
Okay.
we have had a conversation with our colleagues at the Department of Human Services, and they've decided to operate the call center in-house. Well, I don't want to speak for them, so
It's okay.
they've.
I'm on that committee, so.
They're not utilizing us.
Okay, they're not utilizing you.
Yeah.
Okay. Okay, at last year's performance oversight hearing, we talked a little bit about the Healthy Corners program, which I think has been an excellent creative way for us to try to help corner stores around the city introduce more fresh fruits and vegetables and produce into their stores. You all indicated last year that you were considering implementing a tiered funding system so that stores with more fresh produce would be eligible for increased funding, et cetera. Did you guys do that?
We did not. So we've been partnering with DC Central Kitchen to pilot this kind of incentive model so that there's levels that can incentivize a corner store owner. So we're actually about to release the 4 RFAs for our 4 healthy food access initiatives. So encourage all of our CBO partners to apply. And with this next 5-year cycle, we can look at implementing that type of tiered corner store model.
Okay. In the pre-hearing responses, you all stated that your WIC team engaged with Aldi and Dimped in a fiscal year 25 to try to get Aldi to accept WIC. I will just note for the record that accepting WIC is a requirement for the supermarket tax incentive program. But you all stated ultimately Aldi could not participate. Was this for the H Street location or for the other location?
For either locations. The Aldi and any big box supermarket, what we've observed is they have to make that decision at a chain-wide level. In order to carry certain brands of food,
Right.
infant formula, Aldi and Lidl were not able to make that change at like a national chain-wide level.
Okay. So did we give them the tax credit?
That I'd have to go talk to Deputy Mayor for Planning and Economic Development.
It's just something follow up with them, with Dimped. We established a supermarket tax incentive with some requirements. And in a community and areas of the city where we have lots of participants of WIC, they can't even use their benefits at the grocery store for which we are holding ribbon cuttings for, which kind of seems odd to me, but we'll follow up with Dimped about that. I just want to quickly applaud you guys for 2 things. Not just 2, but in this area. So first, the grocery access pilot has been launched. We got some hiccups and stuff like that with Instacart, but we're working through the things. And then also that you all are actively implementing the farmers market support bill, which is a collaboration not just with GC Health, but also with DLCP and some other agencies around that. So we look forward to that full implementation. Do you have a timeline in terms of the application system being complete?
We do not yet. So we have held some preliminary conversations with DLCP, and we're working through our OGR team to convene all of the agencies that we need, including DDOT and DGS and some of the other agencies that were involved in creating the legislation. We've got that meeting on the books. And then when we can convene all the partners, then we can build out that timeline and come back to you.
Okay.
But yes, I have an awesome community health administration team. So
Okay. Okay. I guess we need to take a 5-minute break. So we'll be back. All right. Thank you. And we're back. Okay. Center for Policy Planning and Evaluation. Let me start with some good stuff. Kudos to the improved customer service satisfaction for vital records. And we talked about this last year, and I feel like whatever adjustments you all made there, vital records is definitely a very front-facing part of the agency, and kudos to the work that you're doing there. I want to also commend you guys on some of the newly published dashboards on mortality rates and preterm birth rates in the district. I certainly recommend that the public check out this wealth of information and these new resources. I often get people who are like, there's no info out there. There's info out there. Now, the whole DC Health website needs a makeover, if you will. But that can be said for everybody across district government, not just you all, but there are some good resources there. Let me just ask some questions and sort of some of the data. So we heard some public testimony requesting a dashboard for new HIV cases to better track progress towards the district ending HIV epidemic goals. On its face, that sounds good, but I think there's some challenges with doing something like that. Do you have some thought? Oh.
You can join us. The sensitivity of the data.
Oh, you're turning your mic on.
Between the sensitivity of the data and how low the numbers are getting.
Yeah.
You get to where you have identifiable, at least questionably identifiable people. So a lot of that would be masked. I'm not sure what value that dashboard would have for them. Like what we'd be able to show beyond the 200 over a year. If we showed 3 in a month, that would, and where, or we wouldn't be able to give you any information without feeling like we were outing somebody's information.
That's what I was sort of thinking, but definitely wanted to ask.
We also publish annually in our surveillance report, and we are working on making that into a dashboard that might be updated quarterly or twice a year, something like that, where we could keep more anonymity for the folks who are diagnosed, but information is coming out more regularly.
Okay. All right.
And Clover Barnes, Senior Deputy Director of Hospice. Sorry.
Thanks, Clover. Okay. Death with dignity. What are you hiding? Why can't we get this less than 5-page report out on time?
Sorry. I'm gonna see if any of those folks want to speak for themselves, but it's not as easy a report, and it's sitting in a group that is not really their job. So we're gonna move it to let our CPPE report writing friends do it and not our hospital inspecting friends do it, which is where it's been traditionally. It is not the easiest report in that it's got a lot of documentation to pull. It's a little bit labor intensive, and it just has taken time. So the kinds of information that go into it are not always there, and so they have to go be chased down.
Okay. The last report was published in 2022. It is 2026.
It's a small number of people per year.
I know that.
Yeah.
But I've got members of Congress who
Yeah.
think that the public health agency is hiding thousands of people who are using this because we won't put the data out. So if we're talking about less than 20 people, give me something to quell the madness on the other end of Pennsylvania Avenue. Because when they see a report that's been missing for 4 years, that is when we allow conspiracy theories to flow. You get what I'm saying? Okay. You guys said that now someone from DC Health told some group of public witnesses that you all would be publishing this data by the end of 2025. When can we expect it?
I don't know. It's dignity.
Oh.
You know where she is on it?
Yes. Hi, Carl Filler, Chief of Staff here at DC Health. So there is a reporting lag. So I know the 2022 report was released last year. The 2023 data is now released, and the 2024 data is being finalized. And I will turn it over to much smarter lady.
Renata Cooper. I'm the Associate Director for Office of Health Facilities. So I came to the table to accept full responsibility because I am the person who is responsible for issuing the report. So I did meet with Compassion and Choices.
Okay.
I explained to them some of my difficulties as well, and my intent to be able to issue the report. However, to echo Dr. Bennett's comments, the difficulty is being able to report a completed report.
Okay. Are there some challenges in terms of what the legislation required needed to be reported on?
Not what the legislation requires, it's receiving all of the information from the physicians to be able to report out the information accurately. So just yes and
So yes, so if you didn't want the information from the physicians and it was just the person, and not the documentation to back up the conversation and the rest of it.
Yeah, though
But you need
that's,
that.
you need that. That's
Yeah,
kind of
You
key.
can't not have that. And it's happening infrequently enough that it's an odd piece of thing for them to do.
Right.
And so it's not,
oftentimes there is that we have to contact the physician to, I work with my partners in CPPE to confirm the death of the individual.
Okay.
However, the report, when you review the report, it indicates that the person has passed, but also whether or not the person passed prior to ingestion of the medications or not. That information, based on the law, the physician is not required to be there. So sometimes I have to contact the physician back to say, you submitted this information for this case. Where does this person fall?
Before or after?
Correct.
Okay. Do you have to call the family in those situations?
No. We contact the physician.
Just the physician. Okay. Okay. Whatever we need to do there so I can quiet that side of thinking that we've got some vast conspiracy going on would be very helpful. In FY25, CPPE data shows that there were 20 measles investigation compared to 1 in FY24. We talked about this a little bit. I'm going to move on because I think we talked about what we need to be doing there. Yeah, I think we talked about what we need to get vaccinated people, stop playing. Which is
I'm
like,
just gonna commend the team,
Go take
every
the
one
shot.
of those, because measles is airborne and incredibly contagious and lasts for a long time after the person has left the space. It is a lot of contacts. So for
Yeah.
each one of those, and they've all used.
are you guys doing contact tracing?
Yes.
Oh, I see.
Because people need to be in isolation to not spread it further. So we're contact tracing every one of them, and they've all been on Amtrak, and every single one of them has gone to a march or something. So each one of them is incredibly intensive, and we've had to start to now plan for what parts of the department to pull staff from to deal with each of these as they come.
Okay. When you all submit or issue public health alerts like that, can you, someone maybe in your chief of staff or government affairs, share that information with the council so that we're not learning about the public health alert via the media? I think that would be super helpful in terms of just even kind of disseminating the information as well. The last public health alert on the measles, because of how many different places these people, that sounds wrong. The infected persons went to, it was a broad swath of folks who might not have known that they were exposed, that we needed to communicate that. And I feel like because it was so close to home in DC, right? Sometimes when we get the alerts about, oh, they traveled to BWI and they might have come to Union Station, people are like, yeah, that's not a big deal. But they were on Metro, which I think is a little bit different as well. Okay. That's actually all I have because now I'm going to SHPTA. Look at that. Yay, CPPE. Okay, so SHPTA data indicates that 3 hospitals did not meet their uncompensated care requirements for 2024, and that we issued compliance plans to each of the hospitals. Have they submitted their plans? Oh,
Good morning. My
Good
name is
morning.
Terry Thompson. I'm the Director for State Health Planning and Development Agency. Yes, we have received compliance plans and we are working with our hospitals to make sure that they're consistent with what we would want them to.
Okay.
like.
Did SHPTA issue compliance plans for the 3 special hospitals, the 4 home health agencies, and the 16 ambulatory care facilities that also didn't meet the uncompensated care requirements?
So SHPTA approves the compliance plan, so it's the responsibility is on the provider to submit compliance plan to us,
Okay.
and then we review it. There's often back and forth with the departments to make sure that it covers the information that we're looking for, and then we approve it. So we are approving them serially.
Okay. You all denied 3 CON applications in FY25, all of them for home health agencies. Without getting to the specific details of those particular entities, can you speak to a little bit of what's going on there? Because I think for some people, they're like, we've got a home health aid problem and you guys are denying the CONs for these, these agencies that could be providing workforce.
And we do have a workforce problem, and more agencies isn't going to solve the workforce problem. It then spreads thinner the number of individuals. So we have a pool of workforce that then gets spread across the number of agencies. So what we look for is an agency who has either training programs that will bring new workforce to the district,
Okay.
or a niche where they're seeing a specific population where that workforce is specialized,
Okay.
but not we serve all people for all things and we're pulling from the same workforce that everyone else is.
Okay, so you're being more targeted and strategic around this, so we're not diluting, basically robbing Peter to pay Paul.
Correct. And then the other challenge is looking at finances and making sure that they have the financial wherewithal to get started. Oftentimes, these are new agencies.
Okay.
They're not yet licensed, and they have to go through the licensing process before they're going to get paid.
Got it. Okay. We were happy to see that DC Health published the new health systems plan, but we're concerned that this plan was 4 years late. The district law requires that we have a plan every 5 years. The last one was published in 2017. How are we going to improve going forward?
I'll start and I'll let you speak to it also, Terry. So that plan was derailed by COVID. So it did not start again because, nothing that was done before COVID would have been relevant per se to that report. So it was started again in its development process after the department returned more to a normal level of activity. And so it did take a couple of years, but that is actually the development timeline for that report. From now on, it will be integrated more closely into the health improvement community needs assessment cycle, so that work is being done continually along with those other 2 reports so that they can align and we can sort of see the communication between our health data, what we're saying we want to change around the way we're approaching health in the district, and then our health facilities. So those groups have been meeting around the next report now.
Okay, so what is technically now the new 5-year? So does the count start now last year
Yes.
for the next 5?
Yes.
Okay. Were there any new priorities that we outlined in the plan that you want to uplift?
So the priority areas, we're working around chronic health. So they are still consistent with both the areas that we've had traditionally, as well as those that are aligned with the rest of DC Health. So we can make sure, again, that we're working within the framework of the needs assessment.
Okay. All right. I want to go on to HOSTA. I'll try to keep it moving here. Okay, so we saw a significant increase in new cases of hepatitis in FY25, with Hep C increasing from 170 to 221 cases, and Hep B increasing from 111 to 131. For Hep C, the largest increase was among 25 to 29-year-olds. What do we think is the driver of this increase, and should we have some cause for alarm here?
I'm not sure we have cause for alarm, but we do have more agencies that are doing hepatitis testing and focused on that. And we also know that we have some people using drugs, and that may be part of the issue.
Okay. I mean, in this, oh, sorry, go ahead.
I just want to advise, when we have small numbers like that, when we're talking about 100, 200 people, it doesn't take a lot to get variations. Some people move, or, you know, what is a relatively small group can have a big jump without it necessarily being a big change because the
Okay.
number's so small.
I hear you on that. I think, though, also combined again with the federal government's new approach on hepatitis vaccines,
Yeah.
that I feel like we have to counteract some of the messaging
We do.
around.
Well, they're preventable and treatable.
Correct.
So that is the key, is that we don't have to have it that way.
I know, but I feel like sometimes when people are like, "Oh, it's treatable," they're like, "Oh, okay, well then I don't need to take the vaccine to prevent it because I could just get something later." And I'm like, "No, hepatitis is terrible."
And that's hepatitis C, not hepatitis B. So the hepatitis B that will eventually lead to a cancer or a transplant is not treatable. So there are a bunch of hepatitises. So we should take whatever precautions you can take around all of them. And the treatment is expensive and difficult, even on the one that we can't treat. So wherever there is prevention, people should take it. And where there is treatment, we will offer it.
You know, remember those TV ads that they used to have on like MTV and otherwise about like, it was from this organization called Truth. It was like the dangers of smoking. And the old lady would, not old, but you know, the lady would come on and like she can't, that is scary. Maybe we need to do some more truth telling to get knock some people in their heads around like, why tempt fate when there is a option available to you? Okay. I got more on this, but I'm over my time. We've been joined by Councilmember Zachary Parker from Ward 5.
I love the excitement. Well, I thought I was special. Say it again.
I just said hello.
Oh, hi. Good to see you. Good to see you. I'm going to jump right in. In your responses, you note that HIV prevention services will be scaled back. I wasn't clear if it's will be or they have been scaled back. So if you can clarify there, and just expound on what that might look like on the ground and community.
Yep. So we have received a decrease in funding for HIV prevention
From the federal government.
from the federal government. And then we also are, I'll just say, unsure about the funding levels going forward after May of this year. That is
So right
when-
now, services, at least through May, normal, and then they're in
Finish. I'm
okay.
coming for you. Give me 1 sec. Okay, so because our grant was late last year, it was 3 weeks late when we got the grant. We could not continue them in the same way. There was a provision in the federal grant that we had to have our budget approved by CDC before we could fund any programs or any people other than our personnel that was approved on the budget. We did not get that approval until after the government shut down. And so we are just funding those providers now to resume their services.
So were services disrupted?
Yes.
For how long?
About 7 months.
Okay, and what is the impact of that? Or can you just speak to the magnitude? How many programs or FTEs are we talking about that were out of service?
So we kept all the FTEs, much to the chagrin of some of my fiscal people. We didn't let them go. We kept them until the grant money came in. But there are 10 providers who have their grants being restarted now as we speak. We actually put that stuff through this week. And so they are having their grants restarted. So that is community programs. We still had test kits that we had purchased internally. And so we have been giving those to our providers to use for their testing efforts. It has decreased the number of condoms that we have available to like mail out to individuals. We still provide them to schools and to other entities, but it did decrease the number that we were able to purchase and put out. And then it decreased the amount of services that we provide internally when we go to outreach fairs and community health.
And just to make
events.
sure I'm super clear, so the grants are being issued now, that will fund these organizations through when?
Through May 31st.
Through May 31st, and then it's the Wild Wild West after that.
Correct. So let's just say what's happened nationally is that they funded the federal grants to go through, and they have put out the mechanisms for that to happen. However, 4 jurisdictions have had their funding rescinded from CDC already. All their HIV funding, Colorado, California, Illinois, and Minnesota. And so we are unsure what will actually happen when it comes time for the grant to be funded. But we are planning for the worst and hoping for the best.
So HHS made a plan that this was not going to happen anymore, and they sort of demobilized and told everyone it was done, and then the appropriations bill level funded it. So what that means in terms of whether or not
Yes.
they have any discretion to not then give us the money is unclear.
I actually
And
saw a
whether they can do
report-
it in the time frame that they've left themselves.
I actually saw a report on that this morning about how the rhetoric of the president and the funding that has actually been approved for a number of agencies.
It's not just rhetoric.
It's
Some
not
people
aligned.
fired that entire office. So there's no one there to do the work on some of the different things that we have funding apparently returned for. And it wasn't returned to us. They have an office have it to re-grant. That doesn't mean necessarily giving us our funding, or if they have to do a new RFP, if they can even get that out and approved by the end of the year. They've given themselves some timelines. What's left in terms of time is really difficult, and the staffing may not be there. It's
Understood.
a little bit the wild
So
wild
it
west
sounds
at
like
HHS right now.
you're planning as if we won't have the funding.
Yes.
And how much funding is that, to be clear?
It's $7.5 million.
And I know we, as a council, replaced, I want to say 1.2 million of that.
Correct. Thank you.
And that'll get people.
And that we're using that for the gap between what we've had that allocated for is the gap between June 1st and September 30th, the end of the fiscal year.
Which will hopefully give us more time, if they are going to give us the money, for us to try to avoid a gap in services. My fear is that even if they gave it to us, their timing will be so off that
Yes.
we would do what we already had happen.
Okay, so it sounds like you have funding at least through the end of May. The funding that the council was able to secure will bridge you at least to the fall.
Yes.
And then, okay, that is helpful. I did want to keep going. I'm glad that the PrEP DC Act is moving forward through the council, and thank you all for your support of that important legislation. According to your responses, PrEP coverage has been above 50% since 2021, reaching 67% in 2024. How might coverage for PrEP be impacted, if at all, with some of these services that are being scaled back?
So prevention is what leads to PrEP. So we have a status neutral approach to our HIV services, meaning that there's no wrong door that you enter through. So any person who comes in, whether you know your status or not, you're offered a test. If you're positive, you go on one pathway. If you're negative, you go on another pathway. If you're negative, you go on the pathway to be case managed into PrEP. Like our goal is to get anybody who's at risk for HIV and negative onto PrEP so that they don't get HIV.
But obviously, if we have fewer community partners,
Correct.
Right.
that there's
Or
less of
fewer
that
doors.
There are fewer doors for that. to
Fewer
go through.
doors.
Correct.
I will just correct, it's even if we get the prevention money back, there is still some question around PrEP, because some of what allows for coverage are the federal standards around what health insurance will do. We've had some conversations. I think everybody's committed to still continue things. Whether they would have to or not would be up to question. Whether Medicaid or other programs would be able to or not is under question. There's a lot of
And
unprecedented.
would not the legislation we passed
Well,
help with that?
it will help with that. But since it's kind of unprecedented for this to happen, it will help. And I'm not sure how we, if we're aware of every consequence of them making changes that we as yet haven't seen.
Understood. Okay. I did want to pivot. I have a long list of questions. Just given the Potomac spill, and I know that's not directly up your lane,
It's a
but
whole day, every day. Go
it
ahead.
does relate to the health of our region and the health of district residents. Two-part question. Can you speak to what role DC Health is playing in the response with the spill? And two, is there any concerns about lingering impacts from the amount of sewage that is being dumped into the Potomac River?
So one, that's past tense, not current. So there was a big spill and then there was an overflow some weeks after that. So we have been watching the data since then to see what would happen as that spill, which looks quite impressive on a satellite, but as it washed downriver towards DC, what would happen?
Can I jump in and ask another question? Sorry, I'm looking at the clock. We had this discussion with DOEE as well as DC Water. They are tracking E. coli levels.
Yes.
Should we be looking at other things as well, or is E. coli the standard we should be monitoring?
E. coli is the standard as an indicator of all the other bacteria. So it's not that it's the only bacteria, but it's the most prevalent. It is it's the one that's going to grow the most. So your levels of all the other bacteria are likely less than the E. coli, at best equal. So the E. coli gives us a sense of where everything else is. So we know from Maryland's labs that there is some methicillin-resistant Staph aureus in the water. We don't have any reason to expect those numbers are anywhere near the numbers of E. coli. And so as the E. coli numbers wash away, and they have pretty consistently done that, we expect those other pathogens are going along the same route.
And there was some discrepancy where the director of DOEE in a briefing with us said, yeah, I would eat fish from the water, and then it was kind of walked back. Does DC Health have a perspective around how residents should be engaging with the water? Because we've heard reports that dogs are drinking, kids are playing. What is the response from DC Health?
Other than a brief period, the waters right around DC have not shown increased levels. There's been a gigantic amount of sewage spilled above us, and it's kind of slowly washed away. We have seen a blip or two, but for the most part, it's diluted enough by the time it gets here that our levels have not seen a rise. We have had an abundance of caution while we are sitting downstream from a big spill of sewage to let that wash away and not be at risk of big declinations in our levels while it's there. It's mostly gone now. And so we're at the point where I feel more secure about, with daily monitoring, feeling like we are going to be stable at these levels. I don't think that the numbers that we're seeing mean that people were likely at great risk. For the kids who did go in the water, very cold, but okay. But I did want to be sure that we took a breath to be sure that we understood the dynamics of what was going to happen with that sewage as it came down towards us.
Okay, thank you.
You're welcome.
Thank you. Not staying on environmental health, but going back to HOSTA. The pre-hearing responses describe some recent operational changes to the Ryan White program, including changes to providers and service categories awarded by Part A and an unexpected reduction of funding in Part B from Virginia for DMV providers. Can you elaborate on these changes and just talk a little bit about the funding?
Sure. So Ryan White Part A covers what's called an eligible metropolitan area, and that covers the district, 5 counties in Maryland, 11 counties in Virginia, 6 independent cities in Virginia, and 2 counties in West Virginia. And that funding has to cover all of those places because the disease is fluid and it moves across the borders. People live, work, and play across the borders, and that is what is happening. And so because of that, we fund providers all across the EMA. And so in Virginia, what we typically do is we meet with the state health departments of Maryland and Virginia to coordinate what our Ryan White programs pay for so that there's no duplication. We know what they're paying for, they know what we're paying for, and we use the resources to maximize the programs available and services available to people living with HIV in the EMA. Virginia had a reduction in their Part B funding and their rebate funding that they put out for providers in Virginia So that now that they only fund 8 service categories, there are 26 service categories that are allowable by Ryan White. They only serve 8. They used to serve about 25. And so because those services reduced from Part B, we had to pick up the slack to cover from Part A, which
Okay.
meant we had to readjust in the rest of the EMA.
Got it. Thank you. Okay. Yay, kudos and shout out to the Health and Wellness Center team. Expanded hours and days. Thanks to, I love when we give y'all money, y'all actually spend it on the thing. So thank you for that, but also shout out to the team there for the great work that they do. I know it's only sort of been in for a few weeks, but are people going?
They are. And we have numbers. They are going. People, we're open Tuesday evening and every, the first and the third Saturday. And so we have good numbers for folks going to visit. So far there, we offer about 6 appointment slots and they're all full. We also allow for walk-ins.
Okay.
And if somebody like can't come in the morning, but they can come in the evening, we allow, that change to happen. And so that has worked out really well, where we are seeing on average about 5 patients in the expanded hours, and then lots of follow-ups and calls. We also are doing some advertising to make sure people know that we have these expanded hours.
Yep.
So that they know that they have another option to come in and not just during the day.
Great. Good to hear. DC Health installed, I know this is like the weird part where people think it's DBH, but it's actually you guys who installed the overdose prevention vending machines throughout the district. I think the machines are fairly popular. I think it was like 25,000 transactions in FY25 alone. But as we think about some of the changes, again, that's happening sort of on the federal level, where so much of our harm reduction work, or I'm sorry, we're not supposed to call it that.
I was gonna say, you can't even say it anymore, yeah.
What did she say?
Overdose prevention.
Overdose prevention work is tied to federal dollars, and we see that they're kind of fickle these days. So as we think about our strategy on the local side, how do we make sure that we're not 100% dependent upon who is secretary to about whether we continue these activities?
One thing we've done is to work with TBH to look at opiate dollars because those are ours.
Yeah.
And really this is what they're for. And trying to think through gaps in federal allowances as a target for those funds. So right now, those funds will be helping us do some syringe services that they typically haven't done. We'll be looking at then moving SAMHSA funds to do things like we're going to do some street medicine level stuff to try to find the hard to reach people who are, they both have problems that HOSTA is most concerned about, and they have opiate use problems. It is the same group of people. So how do we use those staff to get out to meet them? So I think we're adjusting ourselves. The opiate funds are where we are currently putting our thinking, rather than duplicating or expanding services that SAMHSA would already pay for. Try to really target those to things that they won't pay for.
I hope that in this upcoming budget process, we are thinking about that of like, it doesn't need to be a lot of money in terms of the local stuff, but our dependent relationship, are a unreliable partner right now.
Well, and the gaps are not without consequence for us, right? So we assume people still used injection drugs, whether we were giving them clean needles or not. They don't stop because we have a big break in service. People continue to have partners, even if we stop giving them PrEP or, so all of the people continue on their lives. And so what we most want to do is avoid these breaks in service that take long-standing interventions that were working and then move them backwards. So looking at whether or not we need to find some foundation partners or we need to find more diversity in our funding for things that we've already made commitments to and already have forward movement on successful interventions, so that as they make their changes in their focus areas or allowances, that we don't lose ground. So that is what we've been thinking about.
Okay. In the area of sex ed, so we heard from some public witnesses who testified about the lack of sexual health education that's happening in the public schools. Young Women's Project, they do a survey every year, and they found that almost half of the students, high school students, reported receiving 0 hours of sexual health education in the past year, which not only alarming, but also in contradiction to DC law in terms of what is required. How is HOSTA engaging with the Office of the State Superintendent of Education on health education curriculum standards to make sure that sexual health is up to date, robust? Are we having those cross-agency conversations?
This is one of the reasons that as we took on the school health program, that HOSTA is going to take the lead on the high schools and the health centers, because the needs of the high school students are broad and must include this kind of information and that kind of free access to get that information from whether that's the school nurse or health tech, or whether it's one of our health centers, without some of the barriers that were existing in access before. So that is the goal of moving that program, so that it is more city run and therefore access is free to include this kind of information.
Okay.
And I have a meeting coming up with OSSI
Okay.
to talk about health centers and what's happening. We have done some sex ed in schools based on invitation from the individual schools, but not on the policy of the curriculum. And so we hope to make some impact there going forward.
Yeah. And some of this, again, it's not on you, right? OSSI is supposed to be doing this type of oversight. The curriculum requirements are what the curriculum requirements are in terms of health, not just for high school students, but also for middle school students as well. And, you know, it's not just about teen pregnancy, but chlamydia, gonorrhea, syphilis, like we can go down the list of all the other things as well. Luckily, well, we're happy we're seeing decreases in some of these STIs that I just named. But I don't know, this generation of youth, they are they seek out risk. Like it's
They're
like
risk averse is what it is.
yeah. It's more like I gotta touch it to know it's hot. You just don't want to believe us when we tell you. You don't. Yeah.
In some ways, they're doing less risky stuff than they were 30 years ago. But on the other hand, the kids who are doing the risky stuff have fewer resources and are less connected to things that might help them avoid them. So we've got a much more, I think, risk concentrated in a group of kids.
Yep.
Than kind of broadly spread more likely across everybody. So not everybody's doing anything, but the kids who are having multiple risks and a lot more access to risky things than they might have had before. So
Okay.
we need to find them. And that's one of the reasons I want to have our staff actually physically in the school, really trying to make those connections with the kids who really need us the most.
Yeah. Okay. Let me just ask really quickly about the Child Behavioral Health Services dashboard. What's the anticipated launch date?
Is that the thing that goes with LinkU?
Yes.
Okay. I'm like, that's me, but it's not me. Right?
Okay.
So I believe it's on target. It is
What does on target mean?
the LinkU folks are working with DBH to get all of that done. But I'm sorry, I don't have like a very detailed update for you.
Okay.
They are content.
But you guys are
responsible.
We are
Conversation. LinkU responsible. Yes.
Okay. All right. I'm over my time. Councilmember Parker.
I'll pick up there quickly. You say that the FTE responsible for supporting that rollout of the dashboard started in mid-February,
Yes.
or was hired in mid-February.
Correct.
Have they actually started?
Yes. It was an internal candidate who moved over last pay period.
And it sounds like you're saying it's LinkU's responsibility to actually roll this out. What will that FTE be doing?
So the FTE is responsible for the LinkU maintenance and LinkU partnerships. So what has happened previously is one of our managers who kind of initiated the LinkU platform for our Ryan White clients, that's how it started, learned the value of it and kind of started partnering with other places, the Ready Center, CFSA. And as that happened, it grew and it took more and more of that manager's time to manage those relationships, to make sure that the fidelity of what is going in there is true, to make sure that the funding and MOUs are coming across like they're supposed to. As things were added, like this behavioral survey, like somebody has to manage that, and that person already manages a team. And so the FTE that you guys gracefully gave us is going to take over the management of all those processes to make sure that Link U is accountable to do what it's supposed to do, and our partners are giving the information and everything is flowing in the way that it needs to in order to meet those desired deliverables.
Can you follow up just with the date when we can expect the dashboard to be available?
Yes, I will.
We're really excited about it. And I wanted to pivot.
Okay.
Director, can you explain the role of DC Health with St. Elizabeth's?
So our role is as the hospital oversight. So we have two things we do. We do a annual survey. So we survey to look from top to bottom about what the hospital is doing and its environmental conditions. And then we do complaint-based surveys. So we are alerted to an event or a concern, and then we go and investigate that event or concern.
And what investigations over this past year have been conducted? And I'm asking this because, again, we sat through a pretty damning hearing focused on St. Elizabeth's. And it seems to me that the institution has been allowed to operate suboptimally.
So we have two issues. One, we have had events that we have investigated, and I have a list, which is not in front of me, but we're happy to share that with you, that there have been investigations at St. Elizabeth's. Those don't necessarily include the events that people let you know about during that hearing.
Understood.
Unfortunately. So we need a better system of making sure that people understand where to report these, so that we can be aware of them and go investigate
me
them.
through.
It's very hard after the fact.
Sorry, I don't mean to talk
No,
to
no,
you.
go
I'm
ahead.
just watching the clock and Councilmember Henderson is a hawk on time. Walk me through. So once you do hypothetically an investigation on X issue, what then happens? And what authority does DC Health have for an institution like St. Elizabeth's?
So it depends on what the issue is. So for example, there were some rooms that were cold during the cold snap. We asked them for a plan of how they were going to correct that. They gave us a plan. We approved it. They did that. We had them recheck on a routine basis, and we got it resolved. They have to give us a plan to correct it, and then we oversee.
And what happens if they don't?
If they don't, generally, the corrective action goes through CMS, and we are reporting to CMS that, one, this has happened. We already would have reported that. And then the penalty generally comes from them. We don't have a lot of local regulation enforcement outside of CMS. We need to build that. We're working on that right now. But that is the penalty. If there can be a penalty, they can get fined.
Okay.
We have done some fines.
And then just one more quick follow-up. It seems like the director of DBH, Deputy Mayor Turnage is forming a working group of sorts. I'm going to call it a working group. They're going to meet every 3 weeks or so, so they say. Is DC Health a part of this work?
Not to my knowledge. No.
Should DC Health be a part of this work?
I think we need to, between PIW and St. Elizabeth's, have some three-way conversation about how oversight's going to work. Some of it is a hole in the regulations that we know about and that we are trying to fill, but some of it is just us having more communication.
Okay. I'm going to follow up today actually with Councilmember Henderson as well as Deputy Mayor Turnage and others, because I just feel strongly that we need line of sight into this working group.
Okay.
Now, I did ask the Deputy Mayor, can we join? And he politely, in his own way, said he would rather we not.
He changed his mind.
Oh, he changed his mind. Okay, great. Or you pushed him to change his mind.
We made a request, and so
Okay, so you're joining.
we've got insight.
We could, okay, great. More to come on this. Can we talk about Cedar Hill? Same question.
Yes.
It's a little different with Cedar Hill, I would imagine, in terms of DC Health's authority to hold them accountable.
It is not.
It is
It is
not.
the same. We have a survey to do, an annual survey, which theirs was around licensing at first. So we did that. And then it's complaint based. So we've had complaint-based interactions with them over time. And we will do the same thing that we do.
Can you share, similar to St. Elizabeth's, any investigations that are underway or that have occurred over the past year?
Not so much underway, but we can over the past year. I don't have
Or
them at the top
however
of my head, but
many months
we
since
can
they've
do
been
the ones
open?
that are resolved. There are rules about how much can be shared that are CMS rules, both that cover us and the hospital, about at what point things can be shared with anyone else. And so there are some limitations built into the law
So if you
around how
have,
the investigation's done.
sorry, if you have theoretically a hospital that is not performing how it should, what is the ultimate lever we have to hold that institution accountable?
So there are fines possible for events, and there are mechanisms around CMS and around us doing that kind of behavior. The problem is in general, a hospital is an essential resource, so you're not going to just shut them off. What you want is for them to correct the problem and then to have some evidence that the problem stays corrected. So that is mostly what our engagement is around, getting them to show us that they can correct the problem and then showing that the problem is stably corrected. There are some things around the way we get told about events, and whether or not there is a consequence for not telling us about an event that we need to fix. And so we're in the midst of fixing that right now, because there has not historically been I would say, a downside to not telling us that something happened. And if we don't know at the time, the ability to substantiate an investigation gets quite a bit lower. The patient's gone, the records are gone, the video is gone. So that we know is a hole in our system, and we're closing that now.
Okay, that's unsatisfactory, but I'm
It
gonna,
is.
for the sake of time, I'm gonna keep moving. What is DC Health's approach to dealing with the rat infestation in the district?
So for the most part, it's a complaint-based system, and we go with-
Noticing a pattern here.
No, well, we have to know something's happening. We do have to know something's happening. We have a big purview, and there are only so many triggers that can let us know automatically.
So neighbors are reaching out to say, hey, and I know DC Health is leading abatement efforts.
We are.
Outside of that, which feels very reactive.
Yes, so there's, the plan for this spring is to try to work on, to try to do some proactive work around areas where we know we're getting concentrated complaints, and work on a system where we do a repeated treatment in an area to try to get a few generations of rats, with between anticoagulants and sterilizers, and try to do some repeated treatments to try to depopulate an area, at least temporarily. We're going to see how that works. We haven't tried that before.
And when will this happen?
When it's not frozen.
Okay, so sometime this spring.
We're going to do a pilot this spring.
Where's
We're
that pilot
looking at
going to
some of
be?
the bids. We have to get cooperation and agreement from the bid and from, so we can know that
So
we
it's
can
gonna
get
be an
into all
area
of
and a
those
bid.
areas. It's going to be an area
Let me
of,
guess, is downtown?
it is not.
Okay.
And that was not one of the places we were looking at as a
Because there are
high.
areas in Ward 5, as I'm sure across
sure
the city,
We
that
can do them all at once.
that are
and this is gonna
inundated.
pull the team from what they're doing in the neighborhoods. So we're going to see how much time that takes and whether or not that's sustainable. And we're looking at a couple of areas as the start, and those are the high concentration
Okay,
areas.
quick follow-up, and then I'm, Councilmember Henderson, I'm gonna run and do something, and I'm gonna come back for another round, if that's okay. Just quick follow-up on the rat topic. Respectfully, that feels reactive, and I'm glad you all are doing it. Proactively, is DC Health giving guidance to other agencies, like,
are.
let's say DPW, to say, you should do X, Y, and Z to help drive down our rat infestation?
This is one of the things that we want. When they are working, we have been advising them around some of the trash receptacle issues. The other thing is around our ability to really push someone or ourselves really really force the cleanup of areas where we know it's causing rats for other neighbors. That's where we were talking about earlier, where we don't actually have that authority at the moment. We do have some limited authority around commercial spaces to make an owner do that work. But if they don't, we go through this prolonged NOI process that leaves the hazard in place. And so we're looking to see if we can't reframe our authority to eliminate the hazard. If you don't do it, we will, kind of thing, that we're writing right now to put into a different framework of statute or regulation.
Okay, thank you.
Go ahead.
I wasn't planning to talk about rats yet,
I wish.
but I posted a video last night because I picked up a rat yesterday on a corner where there was a lot of
With your hand on
trap. No,
purpose?
not with a trap.
Okay.
You know, no. I think to Councilmember Parker's point about it being complaint-based,
Yes.
do you have any rats in your alley? I see rats all the time.
Behind our,
I'm just saying, like, if
Yeah.
it takes having a complaint from a resident for you guys to act, are you all?
well, they're always in the neighborhoods. They're always, we have staff in the field all the time. And so
Okay.
they are inspecting and
Okay.
looking around and doing things about the public areas that they see.
Is there a rat task force?
There's a rat
Working
team.
group?
What would a task force or a working group
I
mean?
don't know.
That you-
I've got like 6 different agencies who deal with rodents.
We have
So
had
you
some-
got
so
the
CA
DPW,
yes.
DOB.
Yes, so the CA's office has pulled together on more than one occasion a rat stat. I guess we're calling it that. So there has been some work from the CA's office to increase coordination. That's sort of how we're getting towards other plans and working on some more proactive plans. But we do looking around areas and responding to boroughs when they see them. So we're looking at the public areas. That is what we're doing.
Okay, so let's just talk about the public areas because that's where I was yesterday. There was a
like Aaron
DPR park that the cans were overflowing into the street. And I was just tired of walking by it every day. So I went and got a trash bag, I got a picker, and I went to work. And then that's how I sort of burrowed in. Now, I think overall, we need a different rat strategy because if you guys manage the public spaces, our public cans are just an open buffet.
They are working on changing the public can. So that is something DPW is working on. We've been working with them on that. They've given us some staff to help out. And
Okay.
so we are working together to try to have more coordinated work, but they're aware that the cans are an issue.
Okay. All right, DPW's hearing was rescheduled for early March, so maybe I'll go to his hearing. Maybe I'll go to the CA's hearing. Maybe he needs a whole nother rat stat.
Well, okay. We're still coming out of the last one, so we're still doing some of the deliverables.
All
of the
right.
last one.
In this regard, to sort of connected, not sort of, it is connected to health, it's connected to public health. We heard from our public witnesses that there were 12 cases of pediatric hospitalizations related to rodenticide poisonings last year, and that other states have taken some measures to limit the types of rat poisons that residents are able to purchase and use. Does DC Health do any public education about the dangers of just going out in the alley and just letting it rip on the poison that they get from Home Depot?
Yeah. Do you want to?
Good morning. My name is Dr. Ty Morey. I'm the Associate Director of the Office of Community Protection and work closely with the Rodent and Vector Division. So yes, we do outreach. We have done community walks. We also do talks and presentations that we educate on secondary poisoning. And so we also collaborate heavily with our ANC commissioners, BIS, community members. So we do educate the community on secondary poisoning.
Okay. Should we be doing more in terms of limiting the ability of individuals to be able to just purchase these types of things?
So I think that's our purview. We have to work with the market to not put them on the shelves. I do know the chemical that we use is less toxic, so it's lessen the chance of secondary poisoning.
Yeah.
And our inspectors are very trained. They are abiding by the principles. It's called integrated pest management principles. And what they do, they put the treatment inside the burrows, the rat holes, and then they cover the burrows up.
Right. I think for you, I I have no worries about the trained staff who are doing the rodent control. It is around what is our public conversation of what the harm is to animals, to children. I think this poison sometimes is colorful, right? And so when you're thinking about somebody who's short, right, and their line of sight is different, ooh, something colorful, let me pick this up. I just, in terms of public, I think this is sort of a theme, just sort of in general around like public information as the public health agency around what we should and should not be doing.
I think we'd be open to starting a conversation around that. So it would be within our purview to help legislate, but it would be something that would have to go through you or some other part of the council to enact.
Okay. Councilmember Parker didn't really say, he was advocating specifically for Ward 5. We know where we have the map of hotspots, if you will. And I think it would be a real disservice for us not to try to apply your strategy to some of those.
That is how we're picking the spots.
Okay. I represent the whole city, so no shade to Ward 5, but there are some other parts of the city for where it needs some deeper assistance on this particular issue. Okay, let me go back to where I was going, which was health systems preparedness.
Okay, give us a second.
Okay, we're gonna start with licensing. Okay, so average license processing time increased 5%. Is this mainly due to our switchover? To now we're doing by birthday, so are we doing it's by birthday now? So like we're seeing a bit more people come through, or
We're seeing fewer people. I'm not sure what you mean.
okay. I mean, our processing time did not improve. And in fact, went the other
Well, we
way,
haven't
so
implemented it all the way.
Okay.
So we've only gotten partway through that process, especially the numbers that you're seeing, which are a touch behind where we are right now. So we're implementing that now. What I'm hoping is not so much for a change in the average. The average that you're seeing is the way the system works. It doesn't necessarily give you the number that you think you're getting.
Okay.
So the way people open an application, it doesn't require you to have finished all of the parts before it allows you to submit. That's just the way the system was built.
So if I open
And
up the
there's-
application, I just put my name in.
Yes.
Oh,
So we can look from completion of record, but then there are some professions where the application is deliberately left open while you complete 120 days of training, or while you do, take 3 months to do a test. So the application opening time isn't very useful to judge the processing time. From the time it's complete to the time we approve it is just days. But it's the getting it all complete that takes forever. Some of that is us in terms of, do we need everything we need? Like, we're going to do some value stream mapping to see, are all the parts of this as necessary as we think? Are some of them too hard to get? So that work is going to be done. But some of it is just the mechanics of getting people's applications together. They have to get their references.
Yeah.
Until
Okay.
the last reference gets received, their application is open. So it's an imperfect metric. We've tried many ways to fix the metric, and it will be fixed as the licensing system improves.
okay. So last year we talked about, DC Health testified that you guys were working on software updates to update the licensing system on the applicant facing side. What have we rolled out? What improvements?
Good afternoon. Sam Hurley, Senior Deputy Director for the Health Systems and Preparedness Administration here at DC Health. So over the past fiscal year and to date, we have implemented several changes to our licensing system. Pardon me, including clarifying some of the language and instructions. We have updated our checklist sheets for some of the license types so that when you begin an application, you know exactly what you need so that when you start that application, which expedites processes on that side. We also have, we are in the final steps of deploying a licensure management system for EMS, which may be one that we end up transitioning all of the other licenses to. So it is, instead of a bespoke, custom-built licensure system, we will use an off-the-shelf licensure management platform
Okay.
that is used for other license types, but we have to make sure it works for what we need. And so we know that 26 other states use this licensure management system for EMS. And so we're piloting it in that space because we know it works there,
Okay.
and testing it to see if it will fit for our other license types.
But on the applicant facing side, does it give you the opportunity to kind of see where you are in the process?
So that is one of the deficiencies of our current system,
Right.
is it doesn't give great transparency to the applicant to understand exactly where they are in the process. Or if you have something that comes up while you were filling out the application, you can't stop and restart, which is a problem. So that is something we are working to address, is whatever solution we move towards or whatever changes we make to our existing system need to bring about those improvements so that you don't have the frustrations of someone having to submit an application 5 times because they couldn't get back into the original application.
Right. I mean, I was sort of thinking about from the perspective of like, sometimes with universities or job applications where you could start the process and then save and then come back. That would
Ours
be
does not allow for that.
interesting.
Yes.
Okay. All right. On the question of change to birth month renewal. So we heard from a provider who testified. He was required to pay the full licensing renewal fee twice in 13 months.
Yes.
He raised a reg that does exist, DC Reg 4006.4, which states, quote, if the director changes the renewal system in order to permit an orderly transition, the term of license, certificate, or registration that is in effect on the date of the director's determination may be extended up to 3 years. So why has DC Health been requiring providers to renew in less than 2 years when you all have regulations that allow for you to extend?
Go ahead.
So part of this is because when we are making the transition to the month and birth year, currently we have, let's say, nurses. We have 30,000 registered nurses or nursing staff that are renewing in a 3-month period, one time every 2 years, right? So if I give everyone a 2-year license on their month, that means there's going to be 1 year, which is famine, and 1 year that's feast. So I have to have them staggered. That's why we do birth month and birth year for this transitionary process, is otherwise I will have even years will always be the nurses, and odd years there won't be anybody because it will only be new nurses who come in throughout the year. So we had to have a mechanism for this transitionary period where we spread them out over a 2-year period. The problem is that we couldn't go over to the 4-year mark. So that's why we ended up in this window where we had some licensees that were shorter than the 2-year period. For many of those individuals who were the 13-month that had really short licenses, we've actually reached out to them to extend their license for an extended period, so that they don't have a super short license. In addition, we have also decreased the continuing education requirements for those individuals because they would have spent hundreds of dollars doing continuing education, and we have cut them in half for all of those individuals who got less than a 2-year license. They all have their continuing education cut in half.
But we had to go through each board to do that, so it's just taken a little bit.
Okay. Can you guys reach out to the witness who testified?
Absolutely.
He wants a refund, but I
He's
think
not gonna get it, but he should have gotten a new license that is not 13 months.
that
should
should
have already happened. So
Okay.
if that didn't, then it's an error and we should talk to him.
Okay. If you guys could just follow up,
We got it.
that would be good. On this question in terms of licensing and how we set the rates. Okay, so we heard from the DC Dental Society that the registration fee for dental assistants in DC is significantly higher than Maryland and Virginia. So we charge $240. Maryland charges $80. Virginia charges $100, respectfully. Dental assistants is supposed to be an entry-level position, right? You come out of high school and this is something that you can do. When we set rates for these new license types, are we not doing a survey of what the rest of the region is charging before we set our rates? I think, less competitively than everybody else.
Dental assistant. Dental assistant one is the only one that is only a high school equivalent. And I'm
We have
not
a lot of them. We have a lot
sure
of-
we set a different rate for dental assistant one as we did for dental assistant three. So I would have to look into it.
Okay.
So yes, we should look at the competitive rates, but it's also the process. That essentially pays for the processing. And so it's somewhat weighted for the staffing and the board that go along with that. Yeah, so we set a level, and it's not 240, it looks like it's 160, but we set a level rate for all three license levels for dental assistant, which do include different levels of training. So we'd have to look at whether or not we could regulate that differently.
Okay. I'm going to say that for not just for dental assistants, but in general. This is across the government. We've been very much operating for a very long time as though DC was the hot place to be and everybody just going to have to fall in line and do whatever, right? And now we're not as sexy as Maryland and Virginia. And so we really have to look at our competitiveness in terms of rates, fees, fines, et cetera. And even on something like this, where I need dentists to operate in the district. I need dentists to participate in the Medicaid program. They need dental assistants, dental hygienists, et cetera. If someone doesn't want to get licensed in DC because we're asking for way more than everybody else, I think that's a problem for our workforce issue. Do we audit our rates in comparison to everybody else, not just for this license type, but for the others?
I don't think we do that routinely.
Okay, I think that's something we should certainly look at, because I think it speaks to some of the workforce issues that we could be having in some pieces. Okay, so we saw some increase in complaints. First, thank you guys for publishing the online form that we have been pushing you guys to do for a number of years. We really appreciate it. We saw an increase in complaints coming from boards of medicine, boards of nursing, boards of psychology. Are there any trends that we've seen there in terms of the types of complaints that have been submitted?
Complaints to the boards
To the
about
boards.
providers.
Providers, yeah.
We have not at this time recognized any specific trends or patterns that are specific to any health profession.
Okay.
But we still, metabolize each complaint as we get them and review them.
Okay. The board's only opened investigation, so they received 286 complaints, and they only opened investigations for 186. What's the standard of you guys going from complaint to investigation?
So when we receive a complaint from a constituent or another individual, those complaints are reviewed by staff as well as by our legal counsel to determine if there is legal sufficiency for us to open investigation. So is there a regulation or statute that we believe may or may not have been violated in this situation, or a standard of care that may or may not have been deviated from?
Yep.
Based on that information, we then either A, refer it to the appropriate entity that may take action. For instance, if there was fraud, that may not be necessarily within our purview. Insurance fraud may not be within our purview. So some of those things may be referred to the appropriate entity. Those things that do remain within our purview, we conduct and begin an investigation on our side.
Okay.
And then we refer that information to the board, the respective board, to adjudicate the issue.
Okay. We heard from a public witness earlier this week with us express some concerns around DC's limited investigation authority under specifically the psychology pack, psych pack. Now, of course, I was like remembering back from when we were having conversations about compacts and what are the limits and dangers of compacts. Yes, I know. Aisha's like, I told you so. When DC Health receives a complaint about a physician who is practicing under a compact in the district, but they are licensed in another state. How do you work with the home state about the investigation?
I think Aisha should come up about that one, but I will say that is the limitation, not to belabor it, but what we give up in order to increase movement of professionals is we give up some autonomy over how they behave. So many of the compacts leave us limited ability to do anything about a complaint like that, and it has to be adjudicated back at the state where that person came from. So can you talk about how we work with other states, please?
Good afternoon, Aisha Nixon, Associate Director for the Office of Health Professional Licensing Boards. So when it comes to compacts and complaints, if a complaint is sent to us and the individual is not licensed within the District of Columbia, we usually forward the complaint in the either to the board where the individual is licensed, their home state, or we send it to the board where the incident happened. Because sometimes the incident may have happened in Maryland and it's a DC licensee, we will do a referral. For the psychology compact or SIPAC, it's two different components to that compact. There's the telehealth component, which is the e-passport phase, and that is the component that the majority of individuals that participate in that compact, that's how they operate. So they are doing telehealth primarily.
Okay.
We do not have jurisdiction over the individuals if they do not hold a license in the District of Columbia.
No, I understand that. What I'm asking though is that when a complaint comes to your attention about a health professional who was providing some type of care or service to a district resident, please tell me we don't just forward the complaint and that is the end.
So we have reached out because the way the compact is, and once that legislation and we entered into that agreement, we gave away our autonomy and our authority to be able to discipline these individuals. So yes, we will reach out to the compact to notify them that we received a complaint regarding a resident in the District of Columbia. However, the decision lies with the home state in which that person holds their primary license.
Do they circle back with you all?
They don't have to. But we will follow up. In most cases, that when we do get a complaint, we are told that the jurisdiction, that is their right. One of the things that is very clear when we are discussing compacts and when we talked about SIPAC in particular, there are some laws that are different. As Mr. Hurley was speaking to in talking about a complaint and legal sufficiency,
Yeah.
it may not be a violation of their law.
Even though they are technically practicing.
Correct. And so if it's not a violation of their law, they may choose to not warrant any disciplinary action. And again, not all compacts are set up that way.
Well, that's what I was going to say. Is this unique to SIPAC or
Yes,
is
it's
this
unique. It's unique to SIPAC and some of the other compacts that are in existence. It is our only compact that we are in the District of Columbia. We are part of 4 compacts. SIPAC is the only one where we do not have disciplinary authority if the individual does not hold a DC license. We are part of the medical compact, the physical therapy compact, and now professional counseling. The other 3, we do have authority to take the license away. We would report that to the compact, and then their home state may choose to take disciplinary action against them. But we do have the authority to remove their privilege.
I will just note the nursing compact is written the same way as SIPAC.
which might explain why we have not done anything with it as of.
Some of the compacts that are coming out, a lot of them are modeled similar to nursing and SIPAC. And so it would remove the district's authority and the board's authority to take disciplinary action.
Okay.
In many states, that's a real minority of the providers in their state because, within their borders, there are only so many people who are crossing into the state to practice.
Right,
For
but
DC, it's usually a large number of our providers are actually originally licensed somewhere else.
Yep.
So if we don't require a DC license and they can keep just their home state license, they just commute in or telehealth or whatever.
Okay, is this unique though specifically for the telehealth portion of the SIPAC? Like if somebody was, let's say my home license is in Maryland, I'm part of SIPAC, I'm practicing, but I have my office here in DC, do the same rules apply?
The same rules would apply if you only, if you're utilizing your ability to work in the District of Columbia. So if they're in DC, they would only be able to be in DC based on a TAP, which is a temporary authorization to practice within the District of Columbia. It only gives them a 30-day window to do that. There are not a lot of individuals that utilize that component of the SIPAC, where they are operating physically within a jurisdiction. The majority of individuals that participate in SIPAC utilize the e-passport route, which is for telehealth.
Okay. This is all concerning. Would there ever be a particular situation where you guys heard enough complaints specifically about psychology and psych that we would say, you know what? Sorry.
So with all compacts, when you enter into that agreement, each jurisdiction does have the ability to withdraw if they so choose. And that would come if based on the number of complaints, and we would present that.
Okay.
I will say the alternative that we use with the nurse multi-state licensees, where we will essentially by endorsement give them a DC license, but it is a DC license that remains subject to the authority of the board. I think that is a solution that we might roll out for other things where we want to use a compact, but the authority does not quite work out for the district.
Yeah, I think that is the question, right? Like, do we want more workforce? Yes. But when something goes awry, do you want to give up all power and authority?
I want to reiterate, compacts don't increase workforce.
Okay. All right. On the same question in terms of licensing. So my office received a complaint, I think, which highlights an alarming loophole in terms of our criminal background check process in terms of licenses. So we don't check criminal records in other countries, which means if, let's say, I have been practicing in Norway for 10 years, and then I came to the United States and I've gone through the licensing process. And yes, you asked me, do I have a criminal record? But I don't think the application does the application say both domestic, like in the United States and internationally?
The current question is all jurisdictions or any jurisdiction. So that for us was explicit to say that anywhere that you have worked or held a license. The other thing is that traditionally, if someone is coming and they have practice as a individual, like a physician, and they are utilizing that license and they're transitioning, they would also come with their verification of licensure, which would also designate if their license was encumbered from that country. Traditionally, most of the individuals that are coming that are foreign trained are not coming where DC would be their first license.
Okay.
And not necessarily someone who is transitioning a license or endorsing into the country. So historically, we have not had a reason to say that a foreign check is required. Additionally, because most of the individuals who are coming based on DC being their first license, they usually go through the visa process, and that also conducts a global criminal background check.
Okay, but we just had a whole conversation about how everybody's standards might be different, and we know, we've checked, other states seem to check criminal records in other countries. Why have we decided not to do so?
I'm not sure if other states check criminal background checks in other countries, because I will say that DC is one of the places that conduct criminal background checks. A lot of our other jurisdictions do not, and that's why they are not in compacts, and they have to get that process started. Most of the states conduct FBI-based criminal background checks, which is that's the standard.
Okay.
I think secondary to that, I would say that most coming from another state, I know that we did criminal background checks in other countries when you were coming to us with a license from another country, and that was the license you were seeking reciprocity essentially with your license from. In Maine, it was in Canada. So I was taking my license from Canada and I was seeking a license in Maine. We would ask for a criminal background check from the Canadian authorities. But if you're coming into our licensing system as a US resident with a new license, not using your Canadian license, but a new license, I was not checking because you had lived in Canada at some point in time, I'm not checking your Canadian license, nor do I have the capacity to check every country in the world.
Right. I'm not saying
So
every
it's
country in
hard.
the world, but if I know that you've lived in Canada for a particular amount of time, I want to know what's happening there. So let's say you had a situation where someone was coming into the district with their license from another country. Do we not check the records from the other country? And I know you said it's quote unquote rare, but like also we're the nation's capital and there are a lot of international folks here. So somebody is coming to the United States where DC is their first.
So individuals do provide their criminal records or certification when coming in. If they're coming from another country, they do their fingerprinting at their embassy or their legal agencies within that country, and then they provide us with the cards and the letter, and that goes through the system that is our vendor. So we have the ability to review it.
Okay. So in this sort of same vein, similar but a little bit different, if you have a licensed health professional that is under investigation, meaning that you guys have determined already at this point that it is legally sufficient or the complaint was legally sufficient enough to open up an investigation, why do we still let them renew their license? Or is it on a temporary basis? Like, or can I get my whole license renewal for the 2-year period, even though I'm currently under investigation for some particular?
So it depends on, first, if you are under investigation, that does not mean you're under investigation for something. There's a wide range of things that are not allowed, that would not be best practice or are not allowed under the law. Not every one of those is an immediate risk to patients, or we feel like you cannot practice at all. So if I'm going to allow you to practice because there may be something that we want to look at that we want you to stop doing, or you may not have done, getting your license renewed does not mean that we have lost any ground. Once the investigation is over, we will make the determination about your license, whether it is a newly renewed license or an about to be expired license, whatever state it's at.
You can continue, like if the complaint is about health and safety.
Yes.
Provision of care, in period of the investigation, you are still seeing patients.
But let me give you the converse though.
Okay.
If one patient has made an accusation that we investigate and it turns out not to be substantiated and you are cleared, do we want to eliminate the oncologist for all of the other people under that person's care while we finish that investigation? So eliminating a provider eliminates the care provider for a lot of people who have not made that same complaint. So we want to be sure we're protecting the public, but there is also a risk to the public of removing a provider who is currently providing care. So we're balancing those two.
Okay.
So there has to be some sense of due process. Every investigation does not arrive at a conclusion that something has happened that endangers all patients.
Sure. Also, just want to make sure we're covering ourselves here. Like,
right.
If there is a serious complaint,
but
maybe not just based off one person, et cetera, but like in the course of the investigation, we don't want to just like, all right, we're stamping you for another.
And that is an option. It depends on what it's about.
Okay.
But we don't want to be eliminating care for people. There is not an endless number of dermatologists or oncologists or whatever this person does. So if I have a panel of 1,500 people, you just removing me does not necessarily guarantee care for those 1,500 people in any kind of time frame. And some people's care is complicated or delicate or requires ongoing involvement of the same person in order to make their care quality. So I don't want to disrupt people's care unless we have very, very good reason, and that's what the due process is for.
Okay.
And I want to make sure make sure everyone in the public understands that if there is a complaint or a situation that we have sufficient evidence and it is to the point where it is so egregious that, we believe that people are in imminent danger or harm by this person continuing to practice, we have the authority and capacity to summarily suspend their license or authority to practice within the district. But it depends on the threat. It's kind of like bail. If there is an immediate threat to the public, then we don't issue bail. If there is not, then there is hey, we're going to investigate this. It's still not over, but you're going to have to be held accountable.
Okay.
And I want to be clear, the DC Health has the ability to summarily suspend a license holder. Again, but that's still a process, and all licensees have the right to due process. So when DC Health receives a complaint or something is brought to our attention that would warrant potential imminent harm, that is escalated up. Typically, it is signed off on, and we make a request to the Office of the Attorney General. They review the supporting documents and evidence, and then they determine if they are going to issue and allow us to issue the summary suspension. If that is granted, the license holder also has the ability to request a hearing that goes before the administrative law judge, and at that time, the summary suspension could be overturned. So it's a process that, again, the applicant has a right. So with an investigation, it's based on an allegation. Typically, summary suspensions are things that we move forward that we have supporting or enough evidence that demonstrate an encumbered license somewhere else, a police report, a conviction. Those things usually allows us or gives us a better chance of it being upheld. When it's presented.
Okay. This is like the second time sort of in the health cluster, the ALJ process has kind of come up. We were healthcare finance, we had the hearing with them. The number of people who are accused of Medicaid fraud and there is evidence of such Medicaid fraud who then goes to an ALJ to appeal, which is okay, the ALJ's got a lot going on over there. Still on licensing. So we've been discussing the community health worker certification, I think for the last 2 years. You guys have previously stated that DC Health was going to submit legislation. Do you still want to? Are you still planning to?
Yes, that is still in the work. I believe it's being submitted in the most recent updates or amendments to the ORA. And then we pretty much have the regulations. That's the good thing about the committee that worked on it. When they draft the legislation, they pretty much wrote the regs, but that is still in play.
Okay. At last year's performance oversight hearing, DC Health testified that the doula certification advisory committee had submitted recommended regulations that needed to be approved by the full board. In this year's responses, you said that the regulations are under review by the advisory committee. So who's on first? What happened?
So basically, we had a loss to the committee, to the advisory committee, with having the subject matter expert related to it being a doula. The board of medicine reviewed what was presented, but asked additional questions of the subcommittee.
Okay.
And so it went back. We are currently trying to fill that vacant seat.
Okay. We heard from several Wait, who? I'm sorry. Let me go back. Hold on. Advisory committee, you guys get to just name the person?
Yes, so it's just finding people who are willing. We got a recommendation, but that person is not able to. So we're reaching out to other members of the Maternal Care Advisory Committee to see if they know of anyone who would be interested in serving in that space.
Okay. We heard from several genetic counselors who were eager to be licensed in the district, which again, we don't often get people who want a whole license. My understanding is that genetic counseling is licensed both in Maryland and Virginia. It's not licensed here. What are our thoughts here? are you all consider adding this particular licensing category?
So they did reach out to the Board of Medicine, and so they are coming to speak with us to
Okay.
discuss that, and then we would give our recommendations to senior leadership in that space.
All right. So the Medical Society of DC has advocated for several years about DC Health removing particular screening questions that they feel penalizes providers who have a well-managed previous mental impairment or substance use history. And last year, when we asked you about this in the post-hearing responses, you all stated that the agency would conduct a comprehensive review of all screening questions to refine the questions to focus on current and recent impairment to practice safely. Has this review been completed, and what changes have been made?
The review has not been completed. We are almost there. We did take into, so the question was updated based on MSDC's recommendation, and we followed the guidance. I can't remember the organization in the wording. I think it was, I can't remember, and I don't want to misspeak, but we did make changes to the question when originally asked. We are reviewing it. There has been a submission for the change, and so that will be reviewed and approved regarding, and so we got a best practice recommendation from one of the national associations.
Okay. We had an oversight hearing last week. I guess it was last week with the Board of Dentistry. The board chair testified that the board was meeting to discuss the draft regulations to authorize dental hygienists and dentists to enter collaborative practice agreements. Did the board have the quorum to meet, and what happened with these regs?
The board met on Wednesday, and I believe it was passed. I don't want to, I believe that they reviewed it, and it's going to be moved forward to approval through DC Health and then out to EOM.
Okay. So in terms of long-term care, I sent you guys a letter on January 20th. I was asking for an update on the timeline for issuing the proposed regulations for the Certified Nurse Aid Amendment Act. You all responded that as of February 3rd, the regulations were submitted to EOM. When, if ever, are we going to see this come out? It's been a year.
So the timeline for processing through our OAG and EOM and getting to the public does take a couple weeks. It has been submitted, I think, about 2 weeks ago. In my experience, it's usually about 30 days for legal sufficiency and another month or so for approval from internal processes. So I would say another 4 to 6 weeks, but we can try to expedite things and get that done as soon as possible.
I would hope. It's been a year. Do you guys not think that we have a problem in terms of the workforce? I'm just trying to understand. And I think also too, what was very frustrating, we heard from a member of the advisory committee that worked on this. And he testified that they were enthusiastic, they came to the meetings, they recommended certain recommendations, the meetings were canceled at the last minute, and that they never even saw what you guys submitted to EOM. Why didn't we even just do a circle back to share the draft? Hey, we took the feedback, and this is what we're sending.
So communication was provided. The advisory committee was put together. They started meeting in April. They were meeting weekly. Myself and Senior Deputy Director Hurley attended one of their meetings when they submitted their recommendations. Upon review, there were some concerns that we had as DC Health, who are the issuers of this certification. We made some recommendations regarding the changes that went back to the advisory committee. They made those changes. DC Health staff made the changes with legal's help. Then that was presented to the board. There were still some nuances that needed to be worked out, but those things were communicated to the advisory committee, although meetings had to be canceled last minute due to technical issues and staffing changes related to not only our staffing. Again, it was the winter and holidays because their last meeting prior to their meeting yesterday was in November.
Okay.
So we also had some changes where some of the committee members stepped down. So it literally was only 2 committee members. Now we're down to 1. So we have to re-engage and add additional members to the committee. But communication was provided. They may not have seen the final hard copy that was approved, but all the changes that were made were communicated to the advisory committee, either in writing via email or in phone conversation.
Okay. In the similar vein around the CNA pieces, I feel like we've been waiting for a long time on the medication aid pathway, which would allow for CNAs to administer medications under supervision. We've heard from a public witness that 2 training school applications have been pending for multiple years. So at this point, they might not even be interested in doing this anymore. But like, where are we in this particular process?
For the medication, the certified medication aids, we will be rolling out or going live with their application in April. We are currently, we completed our utilization testing because the application was completed. It was dormant in our systems, so wanted to look at that again. We finalized our data sharing agreement with the testing provider, who will then be able to give us scores related to individuals once they pass the exam, and then working on communication plans related to that.
Is the exam ours or is it?
No, the exam is not our exam. It is owned by Credentia.
Okay. Oh, Credentia. Okay. So I want to applaud DC Health for holding these testing events that you guys did for CNAs. It says in the pre-hearing responses, you guys held 4 testing events. Now the pass rate ranged from 12.5% to 20%, which is not great. But yay for effort on you all making the test available to individuals. Like, is something going on with our training programs such that folks are not able to pass? We're not seeing higher pass rates?
So when you learn a skill, if you use it, you know it. And so people are learning this skill in school and then having a big long break while they're unable to get tested.
Right.
And then when they come back to try to do a skill they haven't touched in some time, they don't pass. So getting the testing issues resolved so that people can finish school, get the test, and then use the skill every day in their job
Yeah.
would solve some of that problem. So some of the providers were able to do some remedial learning with folks to remind them of the skills that they maybe had lost a little bit of ground on in the gap. As we can get that gap to go away, it will get better.
Now, DC Health regulations require that a CNA program must maintain an 80% passage rate for first-time test takers to be approved by the board. Are we in compliance?
So that is correct, that we do have the regulations to do that, and we do have some programs that are on compliance plans.
Okay.
So the regulations underneath that are not, if you're not at 80%, you're closed. It's if you're under 80%, then you need to be put on a performance improvement plan. And as Dr. Bennett just alluded to, for the psychomotor testing, so the skills testing, we believe that those numbers may not accurately reflect the quality of instruction as the person graduates the program. But if you're, again, waiting 6 months to take a test, something that I haven't done for 6 months because I don't have a mannequin at home, or, some way to practice those skills, they deteriorate over time unless I'm using them every day as a practicing CNA or HHA. So what we are doing is we are emphasizing the importance of the written exam as a barometer of the quality of the program. And as reported in question 119 in our written responses, we do identify that there are some programs that are not where we would like them to be. And those programs, we are continuing to work with them. We meet with the collaborative of training facilities on a pretty much monthly, if not more frequent basis at least. And we do have corrective action plans that have been put into place by the board
Okay.
for those facilities that are underperforming based on these metrics.
This is starting to feel a little bit like, so in my previous world, I worked a lot on education and higher ed. And boy, we had a time with the for-profit industry where they were taking people's money, giving you a credential, and then you can't pass the exam to actually get licensed. This is feeling like that in terms of, I mean, to what extent do we allow for students to know, hey, you know, Mateo's home health agency over here, they got 100% pass rate on the first time. And I don't know, Sylvia's on this side. She's only doing 40, so maybe go to Mateo.
Because so many of the problems sat with credentia and people's ability to get the test, I think it's a little unfair at this moment to judge them based on people's pass rates in such a disrupted system.
Y'all are so compassionate at DC.
No, it doesn't serve us for there not to be training places.
No, I agree,
So
but it
if-
also doesn't serve us if nobody gets
even the ones that we have a lot of relationship with and have some good sense of their quality, the ATC, others, if they are even having a problem and we know that we're having a problem with the contractor, then the system is disrupted. So I don't want to lose a school that I can't judge their quality because the system is so disrupted that it's created an unfair metric.
So how long do we have to wait for us to be able to
I
judge
think
the
we've
quality?
corrected a lot of the problems with people's access to the test.
Okay.
So that is what all of that work was for. The testing events were just to try to rescue the people who had fallen out of the system because they couldn't get access to the test. Not they couldn't pass the test, they couldn't even get access to get tested. So that was part of the problem. There was a huge backlog. And so some of those people we emergency licensed to hopefully get them into places so they could then regain their skills. And we've done several things to try to correct what was a developed disruption in the system based on access to testing. As we've corrected that, everybody should be back or getting back to normal times.
Okay, just really quickly, assisted living administrator license. Been 8 years according to a public witness. 8 long years.
So yes, it has been some time. The regulations were drafted in 2022. Some of the things that had to be put in place related to the regulations was, again, their national testing. The last final thing is the jurisprudence exam that is part of the requirements, but we intend to go live with that application in April as well.
Okay, do you guys have any concerns around federal requirements late?
In working with the Office of Health Facilities, we are not aware of any federal regulations that is being potentially violated. There's none that we are aware of.
Okay, Councilman Parker.
Thank you. I wanted to talk about animal shelter.
Not it.
Sorry. The auditor found that DC Health did not adequately monitor the previous animal shelter contract. What steps have been taken to ensure that adequate monitoring is taking place under the new contract?
So we've staffed that contract monitoring differently. It was kind of a part of the job of someone who had multiple other functions. So that has been more concentrated in somebody who's going to have that as their focus. Some of what was happening was that the contact we had with the provider, they've been there a long time. We're operating somewhat independently. So we're going to have much more contact. There is a staff member who will be there more frequently. I think he's at weekly at this point, but you'll correct me, Kara, if I'm wrong. So having more on the ground, the facility, we would have been looking at. We were at New York Avenue, but the vast majority of the animals were at HRA's site that they owned. That is no longer true. It's our animal shelter, and we are there fairly frequently. Most of the protocols that existed before were not part of the contract. They're now, that negotiation process and co-approval was done as part of the contract so that there is something stable that we're looking at, that we are holding them to. So the contract was designed better, and now we have better staffing, partly given to us under the new budget, that is allowing us to monitor it better. Anything you want to add to that, Kara? Introduce yourself.
Hi there, I am Kara Dreyhoff. I'm a supervisory epidemiologist with the Environmental Health Administration. In terms of the animal contract oversight, as Dr. Bennett said, we do also do a very formal monthly inspection. We walk through, ensure that all of the components of the contract are being followed. We do now have a DC Health staff member who is on site on a weekly basis, sits there, does their work in the shelter to facilitate communication, as well as to do kind of a quick check walkthroughs, ensure animal cleanliness, enrichment, and exercise is taking place. And then we do receive monthly metrics from Brandywine on all of the elements that are spelled out in the contract, including things like spay and neuter numbers, intake numbers, and outcomes.
That is good to hear, especially the weekly on the ground presence, which from reports is needed. The report also noted that low-cost spay and neutering services were not regularly being provided. Where are we now with that?
I think that's not entirely accurate. The fund that we have for that comes out of the licenses wasn't routinely being used. It was never very high. So it wasn't, the contract covers those services out of the contract, not out of the little fund that comes out of licenses, and it just wasn't being transferred on an adequate basis. It is now, so that fund is being utilized. But the spay and neuter services were being provided even under HRA. They weren't being documented or counted very well. That is no longer true, and so we do have very exact numbers on the number of animals that are being spayed and neutered at our shelters under our contract.
And are we seeing more now?
We did over 6,000 last year in their first year as our contractor.
Okay. And how does that compare to a previous year?
Because they weren't being counted very well, and what was us, what was the contract, what was HRA independently was not clean.
Understood.
We don't really know.
Understood.
But people are getting, we have a mobile service that we were able to purchase a mobile vehicle, and they're doing some in fairs. So I think the feedback from
You're
the
doing
public,
neutering services in a mobile?
we do have a mobile
Wow.
vehicle that we can do surgical. Yep. It just sits there. It's not driving at the time. So close your mouth.
I mean, but that still seems.
It's not driving at the time.
That seems like an
They took it
intense
away.
operation for.
It's not. It's a relatively simple procedure. Do you want to say something, former veterinarian?
Oh, yes, it can be done in a mobile unit. As long as it's not moving, a neuter wouldn't be problematic.
Okay. Well, 6,000 sounds like a lot. But in what I'm hearing from you, we don't really have a good comparative number right now, but we'll use that 6,000 as our benchmark moving forward.
Our feedback has been, for the most part, from the public that when they do events or when they ask people to come, they're able to serve everybody who comes.
Understood. And then I introduced the Care for Animals Act and worked closely with your team. This would, among other things, provide resources for preventative and emergency care for animals across the district. It would also create a new source of funding through pet food registration fees, which will help alleviate some of the cost pressures we're seeing across the board, which leads me to ask, what funding sources currently exist to help pay for animal services in the district? And I'm thinking about the number of animals that go without care because the homeowner maybe just can't afford it.
So Brandywine, both under the contract and also as a nonprofit, does offer essentially low-cost sliding scale services. So many residents have taken advantage of that. So we know that people are at least somewhat aware of it. It's on all of their bus ads that they do low-cost medical services. So we know that some of that is happening. What typically happens in the jurisdictions around us, and we did this work before we started the new contract, is that much of that work is done under the donated funds of the nonprofit who provides the service. That's a little bit difficult for our current provider because they just got here. So they are a new nonprofit in DC and are still building their donor base. But they are offering services right now on a sliding scale, and much of that is free or very low cost. And we expect that that will get better as we find another funding source for it.
And so it sounds like the funding source is more external to DC Health right now.
That is the way, no, right now, a lot of it is falling under the contract. They'll hopefully be able to expand and provide more as they have more donor base to do that with their own funds. But as we could expand our funds, we'll be able to support it better too.
Understood. Can I ask, now, this is tangential. I'm a dog owner.
Mhm.
What regulatory role does DC Health play with veterinary services or hospitals across the district?
So we license all of the veterinarians and
Okay.
are the oversight for all of those
And how-
facilities.
Sorry, how are we managing the costs? Now, this is related, but I am continually amazed at the price tag of services provided for animal owners.
Me too.
But
I've done a CT scan for my dog.
what role, if any, does DC Health play in regulating that? Or are you even able to say you can't charge $5,000 for this procedure?
It's a commercial system, just like our medical system. We don't have any role in how much they charge for medical care or.
Couldn't that play a role in our ability to license them?
That is not how the law works for medical facilities right now. So if we did that, we would be breaking new ground, but that would have to be new.
I'm gonna go out on a limb and just say, it feels like some of these vet services a bit exploitative.
Mhm.
And it concerns me that it doesn't seem like there's any accountability mechanism to ensure that they're not just taking advantage of people when their animal is in a bad
I think
condition.
the only one is competition, and that's very difficult around any kind of healthcare, as you know, because it's not like I can take my injured dog and shop around. So it does have some vulnerability, but it would need new law.
Okay, I'm gonna put a pin in that for now. And my last question, I wanted to ask about the grocery access pilot program in my last minute. We funded this, and by we, the committee funded this in fiscal year 25 and 26 to provide free grocery delivery to thousands of low-income residents. In your response, did you note that Martha's Table, they have distributed 63 memberships to date, but will be on track to distribute the remaining 973 by April of 26. Can you just speak to that? That
So
seems
they-
like
they-
a lot of ground to make up.
They shut down, they don't do the kind of food programs over the winter. And so it was a very long contracting process with Instacart. By the time we got it fully able to execute this program with them, there wasn't a lot of time left in the fall program season. And so when the spring program season opens up again, they expect they'll have enough people to
By
be able to
April.
distribute the rest. We hope.
Now, we have updated numbers. They have distributed at least 300 memberships. And now they've expanded, and they're also distributing memberships. And so this is the FY25 pot of money, through their weekly food distribution events at Martha's Table, which see a lot of folks. So we at DC Health, we're confident that they will distribute the remaining 700 by the end of April. Another snag that happened, we plan to distribute about half of the memberships through our SNAP Ed grantees. Well, that we had to pivot. So we've worked really hard to make sure that these memberships get out to folks.
Okay, I'm at time. If I can ask just one quick follow-up question about eligibility requirements. Is there any consideration outside of SNAP for seniors to be able to participate? In other words, seniors not receiving SNAP to be able to participate.
This year, we are distributing memberships through Martha's Table, through their food distribution events. So that serves a wide number of individuals that are coming because there's some type of household food insecurity, all ages. We're also working with Martha's Table. So there are contributor of these memberships. Number two, through their health education offerings. Number three, through their Healthy Futures initiative, the cash assistance program with Deputy Mayor for Planning and Economic Development for new moms, and then with 2 FQHCs. So there would be seniors represented.
Being taken care of in those other
Yeah.
programs. I got it. Okay, thank you all.
Thank you.
Thank you. Director, we're almost done. I know, we're almost done. But before you leave, Councilmember Parker, I just want to follow up on sort of the animal control, and the vet. I have a dog, and I like my dog, and I think it's a racket too, but you know, capitalism, I guess, is
Yeah.
what they say. And we don't have like Medicaid for pets. I know some people want that, but it's not what we do. But I do have a question. Do we charge a licensing fee for veterinary practices?
For veterinarians, yes.
No, for the facility.
Oh, do we have a licensing fee for them? I don't. Yes, we do.
And where does that go?
Where's their licensing fee go?
Yeah, does it go into a SPR?
Yeah, all of our.
Or does
licensing
it go back
fees
to the
to
general fund?
SPR. No, for the facilities, not for, oh, okay, it goes into the Health Occupations Fund
Oh, okay.
with the professional licensing fees.
Interesting. Might be interesting in terms of, I know this came up in the hearing in terms of folks wanting more access to low cost veterinary services. Now, I say low cost, and I know that some of the advocates want free.
Mhm.
But when we go free, then we're freely paying for everyone in the region, because everyone seems to manage to find a DC address when
Mhm.
they need to. But this might be an effort for us to be able to support some of the spay-neuter activities of Brandywine, maybe?
The fee is $100, so it's not.
For the facility?
Yeah, it's not a lot.
Sorry, hold on. Hold on. So we're charging dental assistants more than we charge for a whole
That's
vet
not what
office?
we charge the vet for the professional license or the staff.
Well, how much
It's not a
Let me go
facility.
back.
It's not a.
How much we charge for restaurants?
More than that, but we also don't charge for most health like, right, you can just put a shingle up and have a primary care practice. We don't charge you anything. It has nothing to do with us. So there's a lot of
Okay.
variation across.
Minus primary care, though, they have a responsibility to accept Medicaid, and in the before times, they had an uncompensated care requirement.
Primary care practice?
I said in the before
Oh,
times.
okay.
Yeah.
No, even just single or multi-doc practices that weren't clinics?
For medical.
Okay.
It's okay. We're gonna unpack this. We're gonna unpack this. We're creative. But on St. Elizabeth, I agree with Councilmember Parker.
Mhm.
The hearing that I had on St. Elizabeth.
Yeah. I saw.
Yeah. Mhm.
We saw.
I have very low confidence in the leadership there. We're gonna have the meetings with Deputy Mayor Turnage and the director there, but I guess I'm conflicted in terms of where you guys say you have limits around psychiatric hospitals when I have also seen DC Health shut down, say, labor and delivery at a hospital that you felt like it was not doing what it was supposed to do. So I feel like on one, we were saying like, nope, you're going to shut down this whole unit. And
We
then
do
on,
have the ability to shut something down. We do.
Okay.
It just, that is a hammer in a low access space. Having that as our only option and not fining, we need better options than that, because simply saying you can't function anymore when we know we don't have an alternative spot for any of those patients is
I hear you on that, but I also would desire for DC Health to be a bigger part of the conversation with the other agencies around how to improve quality.
I think we need to be part of that conversation.
Of what it is kind of happening there. So, we asked for the investigations that you guys have done.
Mhm.
I know it's both annual and complaint based. I know that some of the complaints that we got, you haven't gotten.
Right.
And there are some complaints that we have now forwarded to you all, that we have received the additional documentation around certain things around pharmacy and otherwise. Other allegations, we have forwarded to its appropriate agency because we know that you guys don't do all of those various pieces. But I guess I think it's hard for the public to sort of grasp, not just the public, but also the people who work at St. Louis every day, for us to respond back to them like, oh no, DC Health did an inspection and they see no deficiencies whatsoever in the facility. What's sort of the discrepancy here? Because I mean, the level of complaints that we're getting is
Renata.
broad.
Yeah. So a survey is different than a complaint, first
Okay.
of all. So we're looking at what their standard practices are. And they did have findings on those, and they did correction plans and they corrected those things. A complaint, I'm gonna let you talk in a second, is really focused on the item that was brought up.
Okay.
And so the expectation that people have that if we're physically in the building, we would note something that was not complained about. We can't just do a survey of every chart that's ever happened. It's just, there's no way for us to do that. So we really do have to have something identified to go look for. A hospital is an enormous enterprise that generates a lot of records and events over the course of its normal business. And so knowing where to look in there, we do have to have some kind of idea where we're looking in order to find the things that people are concerned about. I can tell you there's not an environmental problem that we saw that wasn't corrected. There isn't, a patient room that is poorly constructed that we saw and then didn't have corrected. But whether someone was treated a particular way on a particular day without us being told what record to go look for and being able to see in the record or a video that still exists or something to substantiate that complaint, there's really nothing we can do about that. So either we know in a timely fashion and then can go gather information. We're going to have to improve people's ability to let us know.
Is there a way to submit a complaint about a facility anonymously? Because I know this is a concern of individuals who work at whether it be St. Elizabeth's, PIW, or any hospital, right? Like, do they have to identify themselves?
No, they do not. We have an online complaint form that individuals for all of the healthcare facilities throughout the district that we license, you can submit a complaint. You don't have to put your name on it. You don't have to put contact information for yourself. You can give us all of the information about your specific concern. When it's submitted online, it comes directly to our office. If you do put your contact information, like your email on it, you then get a verification, get a copy of what you've submitted. I will say, since this is televised, that is our preference. We also have a hotline where people can call, but we prefer to have it in the individual's own words, so we can make sure we're very clear on what it is that your concerns are. Also, for the public, I would like to let them know we do not divulge who filed a complaint with our office. I know that's also a concern that we hear even when we speak with people, or they're going to know who told you. We have a way of doing what we do without people knowing who told us. And so they can choose that method as well. We did receive the concerns and we watched the hearing and the concerns that were expressed. One thing I think it was notable when looking at the documentation that we received from your office, there weren't names. And so that is the part that makes it very difficult because as Dr. Bennett indicated, it's a hospital or any facility, there's multiple people that receive services there. And so then we're tasked with trying to find a sample of individuals related to that area. There's the likelihood that we may not be able to identify that person. And so then we pick a number of people who may be at risk for that thing. For example, if there are concerns regarding skin conditions, we pick a number of people who may have some type of care need related to that to see if we can identify that person. And then if we're not, well, what kind of care is being provided to those people? And if we see any deficient practice there, then that would be exhibited on our survey, on our report that's issued for them to respond to this.
Okay. So we had a hearing last week with Board of Pharmacy, and I asked the board chair about the process of investigating a pharmacy if staff of the pharmacy was operating under a retired pharmacist license. And she said that it would be flagged by the Pharmaceutical Control Division at DC Health, I think. How often does this division inspect DBH pharmacies?
I'll defer to my colleague. She's on her way.
Okay. Like, do DBH pharmacies get the same review that a CVS or Walgreens
Yes.
would?
They have annual inspections that are conducted and complaint-based inspections that are conducted.
Okay. I'll leave it there for right now. Food safety. Now, normally, we've had, that was a fun area in the past. I love that all y'all like nodded, getting up. But we did have public witnesses who came to testify very specifically about a specific grocery store in Ward 7. So let me ask this. When is the last time DC Health actually issued a fine to a grocery store based on food safety violations?
I mean, we do routine inspection as well as complaints. So if we see something that's a safety risk, we will issue a fine. I am not familiar with the complaint in the grocery store in Ward 7. So if you can send that to me, we can address that.
This is not a grocery store that is a one-off. This is a grocery store that, like, I would not shop there. But it also is like the only one, right? So once you get into these situations where we talked about of like, do we do the thing? Here's the thing. So I've got the list of number of inspections of grocery stores, and you guys only did 50% of the required inspections. Oh, your mic's not on.
Yeah, we are looking at some efficiencies to let people do more stores. What's happening is that we're doing 2 or 3 different inspections at the most problematic stores and not getting to some of the ones where we haven't had any complaints. Not that that's the best thing, but that is what is happening, is that there's enough staff to do all the stores one time, and then we end up spending far more time at some stores. So if you look, the number of inspections wasn't that number.
Right.
That's the percentage.
So I would love to follow up with you guys specifically about this particular location in terms of the number of inspections that have been done. Because I know for some of the folks who are watching, when they say like, oh, unique complaints, they will flood your system with opportunity about this particular store. And I don't want to necessarily lead to something that's not there, but I also want to be able to say with some sort of confidence for both Councilmember Felder and others who represent that community that DC Health has inspected and this has been the outcome or not. Cool? All right.
Got it.
On this same point in terms of inspections, we've seen an increase in the number of inspections of restaurants. We're still not there. In previous years, we've discussed that inspectors prioritize high-risk establishments. Did we reach 100% on the quote-unquote high-risk establishments? You guys said
We
like
reached higher on the
sushi, hospital,
we reached
cafeterias, oyster bars.
Risk level 5s, we have addressed all
100% of
those,
those.
yes.
I'm sorry, say that.
Our risk level 5s, yes, such as sushis, we have addressed all those.
Risk level 5 as in like, oh, the
highest risk places have all been, those do get all inspected.
okay. It would, if you guys can share with us how you categorize risk levels 1 through 5?
Yes.
In
We will do that.
as a follow-up, that'd be really great. Okay. Okay, on animal control, really quickly, and again, I do promise I'm wrapping here. So up until 2025, the animal control contract and the humane law enforcement contract, which is a federal situation, fell under the same organization.
I will correct you. There is no humane law enforcement contract.
Okay.
There's a right to do humane law enforcement that is given by Congress, well, like 100 years ago, to HRA. What was Washington, what is now HRA, and the Metropolitan Police Department. So those are the 2 groups that were authorized to do humane law enforcement for the District of Columbia. There was no law or budget attached. There's no budget attached to it or contract attached to it. It was specifically given to them under the law.
Okay. Here's where I'm going with this.
Mhm.
So we'd heard from one resident, they had called, particularly when we were living in the time of everything was below freezing for a very long time. They called 311 about an animal that was left outside that they felt was
In danger.
yeah, in danger. 311 referred them to Brandywine. Even though the concern was about humane law enforcement,
Yes, we
which should
understand
have
why that
been HRA. So how are you guys working with 311 staff to properly make sure that they are sending calls that they receive to the appropriate individuals? Because I think that's where some of the frustration from residents come in, is that I call 311, 311 told me Brandywine. I call Brandywine, Brandywine tells me, nope, you need to call HRA.
Right.
It's the telephone effect.
So I know there's been some training with 311 staff on scripts for what we want sent where. There's also been training and protocols with Brandywine staff to be able to forward the call and not the caller. So be able to make the connection for people. And I know some of that is happening, but we are looking at how to do that better overnight. It's really the overnight that is more challenging.
Okay.
Anything you want to add to that?
Yeah, we've been having discussions with 311 on how to route animal control calls in general, but I think specifically with HLE, it can be very confusing. So our office is working on some guidance documents for the general public, but also for the 311 call receivers to better understand what falls under HLE and HRA versus what falls under animal control and
Yeah.
Brandywine.
Okay. Speaking of the overnight situation, I think perhaps one of our biggest concerns or sources of complaints that we get from is around Brandywine's after hours hotline not actually picking up or telling residents just call back the next business day. Even in situations that the resident deems as an emergency and Brandywine says, nope, that's not an emergency. Are you all happy with the performance of the contractor's after hours hotline?
We're asking them to work on an improved system for doing that. One, I think we need to refine with them what to do when they have a situation that it doesn't make sense to go out then. I'm not sure anybody needs to call back to tell you about a situation they already told you about, even if you think you don't need to go out until the morning. So there are some things that we're working on with them, and overnights is a current area of discussion.
Yeah, I think the one of the challenges is that the previous contractor went every time. And so people now have an expectation that when I call animal control, regardless of when I call, they're coming. And now Brandywine is like, nope, we're not. So
We're now at the standard of most municipalities, which is unfortunate for people that feels abrupt. But it is a cost issue, and it is a more normal state of being.
I will also say that I'm not sure if the previous contractor went out every time.
Yeah.
Currently, the after hours calls are being received by a third party service who is triaging those calls and will contact the Brandywine animal control officer that is on call for those calls that are deemed an emergency. Brandywine is actually transitioning away from that third party service so that their own staff are receiving those calls to make sure that those are being routed appropriately.
okay. Also in this regard on animal control. So my understanding is that stray dogs who do not seem aggressive or hurt are not considered emergencies, and that Brandywine will wait until the next business day to respond to these reports. Is this a policy that you guys are comfortable with?
It is. Their likelihood of finding a dog that you don't think is aggressive or is attacking anyone in the middle of the night by just driving around is a pretty low. It's not the best use of their time for us to have someone on call just to do that. So
But sometimes it's not, I'm not talking after hours. I'm talking even during the day where we have residents who say, I called Brandywine, I found a stray. And they said, okay, can you hold on to it for a little bit?
Well,
and a little bit now is like 6-7 hours.
We should look into that.
Okay.
I don't know that we've set a time with them for responding time. So now that you've brought that to me, I'll bring that to them.
Okay. I would, let's definitely look into this because I feel like there are going to be some people who are like, well, if you want me to hold on to this dog all day, then I wish I'd never called, right? And just.
So I think
don't have
during the
capacity
day,
to
during
kind
the
of-
day is quite a bit different than overnight.
Okay, great. Give me just a second. Okay, is there anything you want to add that I haven't asked?
I
Councilmember.
think we've covered a good section of the waterfront.
I think we have as well. I will just say, oh, no, I'm going to ask one last question. So just to sort of wrap up in terms of the inpatient psychiatric hospitals and things like that, in our ongoing conversation, you guys have acknowledged that you don't feel that our current regs allows you to do what needs to be done. So you've talked about we're working towards, but like, do we have a timeline of when we want to deploy something?
Do you know where those sit?
Like, we're interested in working with you all quickly on this.
I'll have to get back to you on the timeline. I know that they're in legal, but I'm not quite sure at what point they're finishing them.
Okay. And then on some of these reports that are, I don't know, sometimes when you guys say EOM, I think you gotta be more specific. Is it OAG? Is it in this building? Is it somewhere else? Because it feels like purgatory over here. Like it comes and it sits.
They're long. So some of the longer ones do sit for a while. But we don't always know. But we can we can be as specific as we know.
Well, let me ask this. And from a process standpoint, when you say EOM is reviewing, does that also include OAG?
No, we say OAG when it's OAG.
Okay.
That usually is fast.
Okay. All right. Well, I want to thank you, Dr. Bennett, you and your team. It is 1:30. And I want to thank the public witnesses who provided testimony on Wednesday. I appreciate you guys providing such a robust conversation with us. And frankly, in sort of the format of you bringing up your directors and otherwise, folks have a very, very in-depth understanding of their roles and their programs and the activities. And that's a good thing that we can display that, not just for members of the council, but also for the public to understand. No, our public health agency knows what they're talking about. And while there might sometimes be delays on things, there should be no cause for concern around the level of expertise about the topics that we're talking about. So for those who have not submitted your written testimony for the record, you weren't able to speak today, well, not today. If you weren't able to speak on Wednesday, the committee is accepting public testimony until March 4th at 5:30. You can submit it online at the council's hearing management system. The committee's next performance oversight hearing, this committee's next performance oversight hearing will be on Tuesday, February 24th at 2 p.m. We're going to hear testimony and discuss the FY25 performance of a new part of the Health Committee family, the Department of Insurance, Securities and Banking. So public witnesses can sign up to testify on the council website. It is 1:32 p.m. and this hearing is adjourned. Thank you, everyone.